We've still got a couple with switched off videos.
Yeah, I think we'll let them. So, welcome to Barts Cancer Institute and Queen Mary University of London. I'm Bijan Patel, I'm your course director. Mark Onstein, our faculty, and Malik Arjun, another faculty, teaching faculty. We'll have some rules for the Zoom meeting and webinar, just so that we can discipline ourselves and maximize the time that we have for tuition online. Now, obviously, it is sad that we cannot teach you face to face, considering the spread and rise of coronavirus infection, especially in London. So I'm sure you are better off where you are in a more safe environment rather than traveling by London underground and buses, which is probably a lot more risky. But it is what it is, and we have all seen a big shift in the way we do almost everything in our lives, including teaching. Now, luckily for this particular course, I feel we were at an advantage in the sense, despite the restriction and various universities and teaching courses having to adopt to online teaching. We already had this in place 2 years ago when we launched this MSc course as a global distance learning program. And now I have always been passionate about integrating technology in education and simulation, and including sort of remote training. And as a result, we've been the first to sort of provide, as part of the MSc course, your own personalized take-home box simulator. And it's the same box simulator that you would have been using in the surgical skills lab if you were on campus in the university. So rather than standing in a classroom and practicing, it's something that you will be doing at home in your own time, exactly the same thing. And obviously you can argue that it's not the same, which is true, because when you're there on campus and we have face-to-face interaction, there's a lot more, not only feedback from the faculty, but even within the group, peer-to-peer feedback, and that makes a huge difference here. So I hope you can adapt to this slightly different environment, learning practical skills online. And the way we have modified the course for you guys, because you have to do it in 1 year, because the distant learning version of the course that we have is over 2 years. So that gives us more time to interact with the students, but with you, we have to sort of crash course everything in 1 year. So I made slight change to the course. Normally, from September till Easter time, we are just purely focused on developing your surgical skills. And then from early next year, or just before Easter, we start discussing thesis research method and spend 6 months doing your thesis research project. But I've started I'm going to start things in a bit reverse. So not only you get more time to do your thesis, but hopefully when things open up next year, you can come on campus and then carry on with your practical training, which some of the practical classes and training and all will repeat on campus, subject to lifting of the restrictions at the university and worldwide. So we are, you will, I'm sure you've not received, but you will receive your box trainer in due course. Let me show you. I'll just share my screen. Okay, so you will get your box trainer with laparoscopic needle holder, scissors, graspers, instrument, and all sort of practice models. You connect it to your laptop. So you saw that you will be able to plug in to your laptop, and just as you're sharing your screen, we'll be able to share your screen. And when we have a practical skill session, show us what you're doing and we can give you feedback. Have you all, hopefully, you know, in my email, I had given you a method of teaching that we are adopting this year for the course, which means for your practical skills, you practice on your own, and then also sort of in your own time, practice with somebody else so that you can, you know, observe each other and learn from each other. Record one of the video as I'm recording the Zoom session, have your own personalized Zoom session, and record the video and then bring it along when we have a group meeting, webinars and discussions so that we can give you feedback. So that's how we're going to be doing the practical skills. You must have seen the timetable as well, and the topics that we are going to cover in our different modules. So let me again just quickly go through that briefly. So share the screen again. So that's your practical skills training for the whole MSc course, starting in October with basic laparoscopy skills, which is focused around developing your hand-eye coordination. Then laparoscopic suturing skills. Lap suture 1 is extracorporeal knot tying. Lap suture 2 is intracorporeal knot tying. Then open surgical skills starting in January and February. Basic surgical skills in January and anastomotic skills, suturing skills in Feb. And finally, laparoscopic cholecystectomy in March. So each module, which is approximately 15 credit, lap suture skill is a double module, 30 credit. We've just sort of, for the purpose of simplicity, divided into lap suture 1 and 2. So each module will last for 1 month. And then you have the box for the whole year to keep practicing and training. You'll have your exams, first semester exam in January, where we'll examine you in the lap skill and lap suture skill module, practical skill exams, and along with that, you'll also have an MCQ. Then once you finish your second semester around May time, you'll have your second practical and theory exam where you'll be examined on your bowel anastomosis and cholecystectomy and research method skills. So I hope you had the opportunity to see and the curriculum and the timetables. So these are the topics that we are going to cover in all the modules, research method webinar that we are starting today, and your timetable, which is every Tuesday morning. Morning session is mostly going to be focused on most of the days on research method and the problem-based learning or the PBL or the theory topics that we call for a discussion. Today, for the next couple of weeks, you don't need to do anything, because I understand a lot of you don't have access to QM Plus and the lecture slides, reading material, etc. So that's okay. But in future, what will happen is, let me just show you. So today we are supposed to be starting with PBL LS1 and 2. So you can look it up. What is PBL LS1 and 2? So PBL LS1 and 2 today is history of laparoscopy, an introduction to minimal invasive surgery and open surgery, including advantages and disadvantages. So these two lecture slides will be available for you on QM Plus, and there are recorded videos from these lectures for you to see the slides, go through the lecture video, and when you come here on a Tuesday, it'll be a group discussion and a quiz. So if this was, imagine if you had done your homework and you were here today, our discussion would have been, I would have asked you, okay, tell me, what did Bozzini do in 1806? Does anybody know Bozzini? Yes, no? No one? So I would expect you to know who Bozzini is and what did he do. So what was his sort of significance? When was the first laparoscopy performed in animals? Anyone? Let's go.
1901.
Sorry?
1901.
1901. Close. Who performed?
Wasn't it a German?
Yeah, name?
I think it begins with a G, but I don't know the name. Georg.
K. Starts
Okay.
with K. Kelling. So we'll, for each lecture, we'll have a list of, and I'm calling it learning outcome or points for discussion. And then we'll just have like an interactive quiz or group discussion. So don't expect for the tutor to come here and give you a lecture while you either fall asleep or switch off your camera and disappear somewhere. Your attendance is going to be recorded while you are online. So you have to, you're all enrolled in the full-time course, so you're expected to be on campus. So this is a virtual campus now. So you can't just sort of turn your Zoom link on and mute yourself and the camera, and then I don't know who's sort of behind the screen here. So unless you have some technical problem on some days, I expect you to have your internet, laptop, webcam, everything working. Your attendance is going to be monitored and recorded. And if you don't have 80% attendance, you will get into trouble with the university, and then don't come to me for that. So our webinars are going to be recorded because university is really twitched about how we're going to deliver and what we're going to do. And there's a lot of pressure from the government and the politicians to sort of make sure that the student and the education is not compromised. So even though this is for your benefit and you've paid a lot of money and you're going to spending a lot of your time in this course, because of the way things are, please make sure that you have time, space, and everything ring fenced for the webinars. Yeah. When you're practicing in your own time, that's fine. But if your attendance is not 80%, and if you don't have record of your attendance, then don't say that I was there in the class that day. Because now with digital data, I know today who's attended. From the Zoom account, we can download the participant list. And I will take a screenshot every time to make sure that everybody's over here with your camera switched on. So I'm sorry to be a nuisance, but it is what it is, and it's for your good. Mark, any comments on that?
You're not a nuisance. That's how can this possibly work if people don't attend?
Yeah.
Obviously, if you're ill and there's some reason why you can't attend, you'll let us know.
Yeah, I think the usual rules and regulation apply.
Yeah.
So somebody has posted that the battery is low. So I think for the first week or two, I'm going to excuse whatever excuses you come up with.
It's the technology.
Yeah. So before we proceed, any comments from you guys? Anything you want to add? Any how can we make it more interesting and better for you? Any ideas? Please feel free to throw in. Anyone, you're all welcome to speak. Unmute yourself if you're trying to talk, because you're all muted. So from your friends from other universities, if you see something interesting, something better, something different going on, feel free to mention or speak up as we go in future as well.
Can I just ask a question? Hello.
Yeah.
You know how every year in this degree we have a conference around time? Is that going ahead or not?
There are no conferences taking place in the world.
Not even online?
No, the online conferences are taking place. So you will have online conferences, and you will be attending online conferences. But the face-to-face, there are no conferences taking place anywhere in the world. So unfortunately, you won't have the option this year. But we'll see, as I said, next year if things change. Normally, we all go in November to the Association of Laparoscopic Surgeons of Great Britain and Ireland annual conference. So because this is a laparoscopic course, we normally go to the it's ALS GPI course. This year it's in November, the same November or December, but it's online. So yes, you can go online and we'll register you for all that, and we'll do that. But it's not the same experience. It's just like it's not the same experience learning online, because you've signed up for a full-time course. There are others who have signed up for the online course, which you have the option, but unfortunately you have to adapt to that as well.
Thank you.
Any other questions?
Hi.
Hi.
My name is Kamal.
Hi, Kamal.
I just want to ask, are we going to study all the laparoscopic instruments, just like harmonics and LigaSurg and other modalities of instruments?
When you say study, you mean use them or just
Use
study
them.
the theory?
Use them and the theory, both of them. When to use them, when not to use them, something like this.
You will study about the laparoscopic instruments and their uses and application. And you will be using the standard instruments for training by simulation. You will not be using energy devices, which is diathermy or ligature or harmonic scalpel for hands-on practice or training, because that's not part of the course, and especially remotely, it's not possible to do that. But you'll be learning about the use and application of all the instruments and energy devices.
Stapling, Bijan?
Stapling as well, yeah. So for as I've said, you know, for your practical training, let me just sort of show you once again. Your practical training for the laparoscopy skills, you're going to be practicing these 3 tasks. For laparoscopic suturing skills, you're going to be practicing these tasks on in a box trainer with synthetic models. All these skills are transferable to actual skills in operating theater. Laparoscopic suturing, again, using synthetic models. And this is validated competency-based training curriculum, which is implemented as part of the mandatory training in USA. And in UK, we are the only sort of 2 countries, UK and USA, where we have competency-based laparoscopic training curriculum integrated in our system. I mean, US, it's compulsory, but in the UK at the moment, it's optional. And you may have seen on our website and in my presentation during the induction day about laparoscopy passport. So laparoscopy, you don't automatically get laparoscopy passport by doing this MSc, but you will realize that if you don't practice enough, you will not get laparoscopy passport even if you qualify the MSc, because you've not reached the targets which are set by the Association of Laparoscopic Surgeons and the American College of Surgeons. So it's not easy. It takes you 6 months to reach the target and to be competent. The aim of this course is to be competent and not just sort of try different instruments and different things and little bit here and little bit there. And if you manage to get a competency-based training curriculum as part of your course and certification, dual certification, sort of one is from MSc Queen Mary University and from ALS GBI laparoscopy passport, that will be a real credit in your portfolio.
After you, Bijan, you disappeared for a while, and to me, your voice.
Right. What did you miss? What did you miss? Sorry.
I lost your voice for the last minute or so.
Okay.
I don't know whether other people did.
No,
It may just have been my computer.
Okay. I was talking about competency-based laparoscopic surgical training, and it takes about 6 months to be competent in these modules, laparoscopy skills and lap suturing skills. So even though you will finish the module in 3 months, you will not be competent. You will meet the criteria for the MSc and the university examination, but you will not be competent as assessed by the Association of Laparoscopic Surgeons or the American College of Surgeons. For that, you require more training. What I was saying is the course is focused around competency-based training and not just sort of giving you hands-on training with a little bit of instruments and a little bit of staplers and a little bit of energy devices and trying multiple things. So there's no point in trying multiple things and you're not competent in the end. And it's just so the difference between MSc and a short laparoscopic basic or advanced surgical course is a short courses where you get to try different instruments and different things is good for acquiring knowledge, but not for acquiring motor skills. You are here to acquire motor skills and be competent in laparoscopic skills. And similarly, when it comes to open surgical skills, we are going to be focused around some basic surgical skills and some bowel and vascular and microvascular anastomotic skills, which are all again practiced on synthetic models. And for cholecystectomy, we have virtual reality simulator on campus, and you'll get to use that for performing cholecystectomy on that. We also on campus at times provide workshops for using staplers and using animals tissue for doing bowel anastomosis, and even animal liver and gallbladder to do cholecystectomy. But as I said, at the moment, it's not going to be possible. Any further questions?
Again, Kamal, is it regarding the lab pass? That
Yes.
means after we finish, we have to wait for another more 3 months. To
You
make the
can do lab
experience and
pass
taste.
today or tomorrow, whenever you want. So the lab pass is something that I can organize the day you feel you can meet you have met the benchmarks.
Oh, yeah.
So, you don't have to wait for the MSc, for the module to finish. We had last year medical students who in November, because some of, there are always one or two smart people in the group who had already had some laparoscopic training before joining the course. In the November conference, they started the MSc course in September, and because they had done summer school and they had done other surgical training with me before joining the MSc, they were able to go and get a laparoscopy passport, and not the full passport, because the full passport has 5 different tasks. But they could be competent in 1 or 2 and get them. They were certified in November.
Oh, yeah, that's good. Okay.
So because it is a completely separate part of the course, but because the course is geared towards that, you can do laparoscopy passport training and assessment with me, or in November with ALS GBI, with any of the ALS GBI faculty, and get the passport. But what we are giving you is the opportunity to train, and we are the only sort of course, and not only course, even as a resident, you don't get training opportunity to train for laparoscopy passport.
Oh, yeah. Thank you.
And it is going to be competency-based training for you guys. It is going to be compulsory. You probably know that you get your annual appraisal and you get your revalidation and recertification. You've heard of all that. As I told you, this is compulsory in USA, and in UK, it is just a matter of time before it becomes compulsory. So as part of your GMC license to practice, to maintain your GMC license, you will have competency-based training and assessment every 5 years or 10 years, and you will be doing laparoscopy passport even 10 years down the line.
Oh, yeah. Okay. Thank you.
The US version of laparoscopy passport is called Fundamentals of Laparoscopic Surgery, and they're exactly the same skill and exactly the same thing. But they've been validated in a different way, so the competency criteria are slightly different. But the practical tasks are exactly the same. Tech transfer, pattern cutting, extracorporeal suturing, intracorporeal suturing. So I think my advice would be focus on your laparoscopy skills and focus on the research and thesis part of the MSc as the 2 main blocks or the 2 main learning objectives. Research and thesis, i.e., so that you get a publication presentation out of it, and laparoscopy skills, so that these are motor skills. It's a bit like learning to cycle or swim. If you learn to swim and cycle and pick up good habits right at the beginning of your career, they will last. So you're not going to go and operate in operating theater tomorrow and after 1 year or 2 year or 5 year. And if you don't cycle for 5 years, you don't forget to cycle. Surgical skills are motor skills. You need your finger, you get muscle memory. So all this will stay with you. And then your learning curve will be very short. Once you start in your surgical training, once you start, you'll realize that your learning curve is short. And there's nothing stopping you from practicing, even using synthetic models and simulation during your career, for the rest of your career, especially once this becomes integrated fully as a part of your recertification. So it's not just training and education, but even for maintaining your license to practice as a doctor and recertification, you will have to practice. We are the only in high-risk industry surgeons or doctors, the only field where we don't get tested for our knowledge and skill once you get your FRCS and once you become a consultant.
Oh, yeah.
Today, if I give my FRCS exam, I will fail. I know I will fail.
Yeah. I don't
Because
think.
exam is different, you know,
Mm.
exam it's different, but you know, that's the system.
Yeah.
Mark, do you think you'll pass FRCS? I think you will probably. You're muted, Mark.
Sorry, I stayed muted then. Yeah. No, I'm sure you would. I'm sure I would. But
No,
it'd be
I mean,
a narrow.
I don't
It'd
have
be a narrow
confidence.
thing.
I don't have confidence in myself that I'll pass the FRCS exam if I go for
Yeah.
that today. Anyway, so I think that's enough of introduction, and I'll move on with. So today we'll just take lectures for you. The two topics that I want to cover is history of laparoscopy. Again, the lecture is going to be available for you to see on online. And introduction to minimal invasive surgery. And after that, Mallikarjun will start with research method teaching, literature searching. Okay, so we're going to be running both the modules in parallel. Malik, are you okay for timing? Stop, unmute yourself.
I'm okay, sir.
Okay, so I'll finish the two things first. And Mark, and any questions, please put it down in the chat box. And Mark, if you could just answer any question as we go, if they come along, or you can interrupt me and
I'll keep an eye on the chat box.
keep it on the chat box.
Okay.
Okay, so let's share the screen again and go back to the beginning. History of laparoscopy. So our aim is the end of the session, understand about evolution of laparoscopic surgery and see where we are in terms of open and laparoscopic surgery. These are the sort of learning outcomes which in future we would be using as a quiz rather than a PowerPoint slide presentation as I'm doing just now. So while innovation in technology can produce great benefits for the patient, the most significant advantage for the individual patient come from the thorough and even obsessive application of current knowledge and technique. So the keywords over here are sort of thorough and obsessive application of knowledge and technique. So what we are going to be doing in this MSc is being thorough and obsessive about the technique of your laparoscopic skills. So potential advantages: less trauma, early recovery for the patient, less pain, fewer complication, quicker convalescence, few adhesions, and ability to sort of re-laparoscopy if complications are suspected. But as you can see in the red line, all this can only be achieved if an operation is performed competently. And hence, so we are going to be focusing on your competency in laparoscopic skills. So why adhesions are important? Because adhesions cause a lot of problems. Chronic pain, intestinal obstruction, strangulation, perforation, etc. And hence the obvious advantage that with laparoscopic surgery, you get less adhesions. So let's look at some of the historical perspective. How did we reach where we are and who were the early pioneers? So we spoke about who was Philip Bozzini. So as you can see from here, he developed lactyliter, which is a light conductor for diagnosis. So this is what it looked like, a sort of a metal instrument of different size and shape to put in different orifice, ear, urethra, bladder, and he even used it for sort of examining gunshot tracts or extracting bullets. So this was the beginning of minimally invasive surgery. Antonin Jean Desormeaux in 1853 improvised the device which was used by Bazzini, and he created a paraffin lit endoscope. And Bazzini used his device for diagnosis, whereas Desormeaux started doing therapeutic procedure with such as chemical cauterization, and he was the first to use it successfully on a living patient for doing therapeutic. Kelling did the laparoscopy in dogs. That was the first laparoscopy. Then Jacobius of Stockholm claimed to have done the first human laparoscopy and thoracoscopy in 1910. But Kelling claimed to have carried these out without publication, so he lost out. So you see why it's important to research and publish. In 1923, Kelling, reflecting sort of a German post-World War I economic chaos, suggested that he was compelled to laparoscope patients to spare them the prolonged hospitalization. So you can see how early on people had realized that laparoscopy or small incision causing less trauma to the patient will have obvious benefits. Some other pioneers. Audouin in 1920 developed the sharp four-sided pyramidal trocar. If you have seen a metal pyramidal trocar, this was the first developed in 1920. Zollikofer in Switzerland in 1924 substituted oxygen by CO2. As you know, in laparoscopic surgery, we have to create pneumoperitoneum because your abdomen is normally collapsed. So you insert a trocar and put some gas inside. So previously, they were using oxygen that was easily available. But then they realized that oxygen is flammable and substituted that with carbon dioxide. So Fevers in Germany in 1933 reported the laparoscopic cautery to excise post-operative adhesions, or carrying out adhesiolysis. He was still using oxygen those days, and one patient actually exploded, but without any serious sequelae. So thus the therapeutic abdominal laparoscopy really began with the Big Bang. In your laparoscopic suturing module, you will learn about extracorporeal and intracorporeal knot tying and suturing. So which began in 1972 with the Roder's knot formation and endo loop formation. You will learn how to make that as part of your lap suture module. In 1980, ski needles and needle holders, and those instruments were developed, and endoscopic suturing started in 80s. Does anybody know who's Kurt Sem? Yes, no? I take it no. So apart from Sam doing extracorporeal knot tying and this endo loop was made for tubal ligation in 1972. So the Roder's knot, which is also used for extracorporeal knot tying, was used almost after 10 years by Sam for doing extracorporeal suturing. So this is again another skill that you will learn as part of the course. Verey's needle. Does anybody know who was Jono Verey's? 5 seconds to answer.
He's a Hungarian doctor
Yeah,
who
correct.
came up with the needle where it's spring-loaded so that it doesn't puncture the soft viscera.
Correct. So he sort of invented the spring-loaded needle, and this was used to collapse the lung for tuberculosis in TB patients. But now this is commonly used, especially with the gynecologists all over the world, for creating pneumoperitoneum. So this is what it looks like. It's a spring-loaded needle. You go through the tissue and you hear a couple of clicking sound as you go through the tough layers of the abdomen, starting with fascia. It goes very easily through the muscle and the fat, but then when it comes to peritoneum, again, the blunt tip retracts and the sharp tip comes out. It's spring-loaded, so that as you go through the soft part of the abdominal wall, you have blunt area, and the sharp tip only comes out when you encounter resistance. And the reason being, when you're in the abdomen, you don't want to damage the intestine, because otherwise the tip of the needle could damage the intestine. So as soon as you enter hollow cavity, abdominal cavity, through the peritoneum, you hear one click, and then you have the blunt tip, which should protect the bowels. So who was Harold Hopkins? You can see he was professor of optics in University of Reading. What did he do? Does anybody know? So I take it no. So he created the first rigid laparoscope. And you can read up more about Harold Hopkins and his optical devices on QM+.
It was a cystoscope, Bijen.
Cystoscope, yeah.
He had a friend, there's a Liverpool urologist whose name I've forgotten.
Yeah.
They met and they started talking, and
he
pointed
started
out
with cystoscope, and then the same thing was adopted and taken up by Storz to make a laparoscope.
Yeah. I've got one question while we're talking.
Yeah, go on.
Jeremy has asked, what's the difference between convalescence and recovery?
Anyone? Recovery is out of the, when the patient mobilizes an operating theater, is before discharge from the hospital. And convalescence is when you're discharged from the hospital home and you're recovering.
And you're still, yeah, the time it takes to get back to your
yeah. So the time
previous
from,
state.
yeah. So the time it, for laparoscopic surgery, once you have finished the operation, out of the anesthesia, the time it takes you to mobilize whilst you're in hospital, even, getting out of the bed, and there are other metrics which are measured, is early compared to open surgery. And convalescence is also rapid with laparoscopic surgery once you go home, which is what we measure by return to work. When does the patient go back to work? So does that answer your question?
Yes, thank you very much.
We ought to, while we've stopped, I'm sorry, BJ, the point about the rod lens is that it changed previously. There was an airspace between a series of lenses, or ordinary, inverted commas, ordinary lenses. And what Hopkins realized is that you could change, if you change the airspace into the lens, to have a long glass lens, and the ends will be convex or concave, you get a much better image. And that also led on to fiber light. Are you going to say something about that? It's the concept of the rod lens that allows fibers to work. Fibers are just one long glass. Well, they're not one, they're hundreds of long glass fibers enclosed. And as long as when it's made, it's a circle, and you cut it across, so the two ends will be the same. That everything will one view of one end is the same as the other. Doesn't matter what's happened to the fibers on the way, whether they got twisted around or what have you. As long as the two end ones are the same, what you look at is what you see. But that's and that's the basis of all all this. Not
Mark,
the
do you want
rigid,
to comment on this slide? You must have done this.
sorry.
Do you want to comment on this slide, Mark? You must have done this.
Well, yes. When I started, yes. This is. There's no TV here. There's no video. The surgeon is looking directly. The assistant is attached, so the assistant's getting a similar view to the surgeon, but nobody else in the operating theatre is getting a view. The surgeon's got two hands free. It's really very difficult, and it allow you to do minor things like tubal ligation by the gynecologists, diagnostic certainly, but to start doing therapeutic surgery like cholecystectomies and what have you, really impossible.
Is it called fiber optic?
Yeah, this isn't fiber optics. This is a rod lens. Yes, because you can't see what I'm doing with my arrow, can you? The surgeon is looking down a rod lens, solid rod lens. There's no fiber optics there. There's the light source. Can you see that the light source is coming across from the stack? That's it. Yeah, thank you, Vijen. Which is just bringing light in. That is fiber optics, but it's not. It's just bringing light. It's not designed to transmit an image. In order to transmit an image, is what I was talking about before, and that's the next stage. But this is how we started. Well, I mean, as I say, the gynecologists were doing something like this for tubal ligations, and certainly I used to do something like this for laparoscopic diagnoses and biopsies. But anyway, it's.
Yeah, I think even not only laparoscopy, but even the endoscopy, you know, if you look at the gastroscopy, colonoscopy, it was performed like this. And a lot of the light was lost because of the additional attachment for the assistant if you were using that. And the rest of the staff in the endoscopy room or the theater suite had no idea what was happening because only one person or two person could see it. So
Maybe a good thing.
Possibly a good thing at times. Yeah. So I won't dwell over this on the important milestone. You can look it up on QM Plus.
But it's the camera that.
But it is the camera, yeah, that changed the
everything.
Video era, yeah. The fiber optics, or the fiber scope that you are referring to, Hirschwitz in 1963 was first to develop and use.
That was an endoscope.
Endoscope.
That was an upper GI endoscope.
Yeah.
Again, I used to do rigid esophagoscopies.
Yeah, ENT still do it. ENT, they still use ENT surgeons rigid esophagoscopy.
Yeah.
Rigid cystoscopy and esophagoscopy, so they can still do that.
Yeah, yeah, but yeah, but. Yeah. Okay.
So who is this?
He wasn't a doctor. Well, he might have been a PhD. I don't know.
It must be. Now you can see what did John Logie Baird do? Sorry? he invented television, and this was the first television transmission, 1924. And once we got television, then we had to stop looking down the laparoscope, and we came into the era of video endoscopy, or video laparoscopy. The father of modern laparoscopy is this guy. So this is sort of in 1985, he's using a box simulator, just like the one that you'll get and you'll be practicing on. So he trained himself using a simulator. So this is talking about simulation in 1985. He was Kurt Sem, the gynecologist. He pioneered minimal invasive surgery, and he's considered to be the father of the modern laparoscopy. In 60s, he used to do diagnostic laparoscopy. And in 70s, again, he did gynecological laparoscopic procedures. Things like tubal ligation and adhesiolysis, simple things. But in 1970s, when Sem introduced the laparoscopic surgery at the University of Kiel, he had to undergo a brain scan at the request of a co-worker, as only a person with brain damage could perform such laparoscopic surgery. So this was the thinking back in 70s and 80s. And it's quite interesting to know that, imagine he had to go through a brain scan to convince somebody and let him do laparoscopic surgery.
There are surgeons who would have wanted to do that when laparoscopic cholecystectomy came in the 1980s, the early 1980s.
Nobody believed that this would work.
Yeah, it was, we'll get to that.
And 13th September 1980 was when Sem performed the first laparoscopic appendicectomy. This was sort of an incidental appendicectomy. And he was severely criticized.
Yeah, he was a gynecologist. What's a gynecologist doing an appendicectomy?
It was thought to be unethical. In his attempt to publish, his paper was rejected by the American OBGY journal. And the president of the German Surgical Society demanded that Sem should be suspended from medical practice. In 1985, so after his first appendicectomy, the first cholecystectomy was performed by Eric Mew using, the information from Sem when he did his appendicectomy. First was in the same year performed in dog, followed by a human cholecystectomy. And these are again some of the pioneers you can read in surgical textbooks, and you'll come across their names if you look at some old publication.
I spent a week with Dubois in Paris, learning laparoscopic watching him do laparoscopic cholecystectomies, and when very few people were doing them in the UK. And I came back and started doing them, and it took off in the States more quickly than it took off here.
That's
right. Perissat, I think, is another gynecologist. Dubois was a general surgeon. His operation was amazing. He'd have patients anesthetized in one theatre while he was finishing off in another theatre. And he just
surgeons those days used to run 2 operating theatre in parallel.
Yeah.
So you could, go from one to another. Now it's unethical and not possible, but
no, I think,
2 or even 3 sometime. You sort of jump from one to another and have an SH or a junior person do a bit, and then he would come and do something.
Yeah.
Kusheri is still alive, and Tempton Woodwardia, I know both of them. I was with Kusheri in January. We were at the same conference. He was my chief guest at a surgical conference. We're still in touch. So this is the advantage. And this is where we moved from open cholecystectomy, where you get a big scar, a lot of physiological response to surgery and trauma that resulted in more pain, poor mobilization, delay in return to work. All this changed with laparoscopic surgery, where if you look at a patient, this sort of on the right-hand side, this is 6 months after the surgery, you can see this little scar over here, very tiny little scar, barely visible over here, epigastric right upper quadrant. So you can imagine the surgical trauma is much less and the recovery is much faster. provided it's done competently. And with technology, you had single chip camera, 3-chip camera, different surgical procedures people started performing. Now, almost every operation other than cesarean section can be done laparoscopically, and transplant surgery. Because you cannot, if you're harvesting a kidney or an organ for transplant, you want the whole organ. You don't want to sort of mash it up. So advances in technology and technique has helped improve surgical care for the patients. This is what we hope to achieve through this course, is make you competent in laparoscopic suturing. This is one of the most complex tasks in laparoscopic surgery, and if you're competent in laparoscopic suturing, then learning any operation is just a matter of understanding the anatomy, pathology, and having knowledge of that disease process or the organ, etc. The skills that you need for laparoscopic suturing are very difficult to acquire. It is often frustrating, and you will realize once you sort of get onto training in this module. But I have no doubt that each and every one of you will have a different learning curve and a different learning experience, but in the end, you will be very good, if not fully competent in training, in laparoscopic suturing. But you've got a year to master this skill and be competent and meet the lab pass criteria, and I'll wish you all the best for that.
Yeah. Bijen, you don't need, the point being that you don't need to suture to do a lap cholecystectomy or an appendicectomy or divide adhesions. And it was particularly the cholecystectomy, the difference between an open and laparoscopic cholecystectomy is so great that it once it took off, it just became the standard operation.
Right.
And it's the difference between what should we call amateur laparoscopic surgeons? Well, no, not really. Many laparoscopic surgeons, so-called these days, even now, can't suture. They can do lap choles, they can do appendicectomies, they can do lap hernias using staples, clips, but they can't do anything else. Any sort of anastomosis, any sort of work at the hiatus to close the hiatus for hiatus hernia. And that's the big difference between the ordinary laparoscopic surgeon and the professional laparoscopic surgeon, which you would all be.
We should all be. I have no doubt about that. And as I said, taking the whole surgical care and laparoscopic surgery to the next level requires competency in laparoscopic suturing. And it is not whether or not you're going to be suturing in future. It is the discipline that you'll develop by learning to suture. It is the ethics and the motor skills and the muscle memory that you will develop that will translate into a better laparoscopic performance on a patient. It is far more difficult to do laparoscopic suturing in a box trainer than in a patient. So, and I'll remind you of that. It's much easier to do it in a patient because of the way things are. In a box trainer, it's sort of a dry, flat environment. The visual cues that you get are very limited. And all these, you're working in 2 dimensions. All these affect your performance. And you learn about that when you read about advantages and disadvantages of training by simulation. So that brings us to the conclusion on the history of laparoscopy. So we'll just take a short.
Can I, Bijen, sorry, can I just have just say something else about fibroscopy?
Yeah.
The point about that I was making about the glass fibers, it allowed endoscopy to start with.
Yeah.
The endoscope is full of glass fibers that are transmitting not just light, but they're transmitting the image. So you have to have the same image at the objective of your endoscope as you have in your eyepiece. So that was the point. And then it's useful. It became part of laparoscopic surgery by when the image from the camera was being transmitted through the various technology to the screen that you look at. So I think, is everybody happy? Do you understand what the two sorts of inverted commas fiber scope, fiber illumination? Yeah, how one is just light, and the other is an image, and the big jump was transmitting the image. They were both big jumps, actually, weren't they?
Yeah, I think so.
Yeah.
I think so. Thanks, Mark. So before we go to the next topic, a couple of minutes, other break or any questions? Hi, Andre. Do you want to introduce yourself?
Yeah, I managed to escape the ward.
Thanks for joining in.
No problem.
So students meet Andre. Andre meets students. Andre is your one of your module leader for lab skill and lab future skill. He's currently working as a post-CCT senior fellow at UCLH in bariatric surgery, and he's a very competent and an able laparoscopic surgeon.
Thank you.
We were discussing history of laparoscopy, Andre.
Yeah. I think of the imaging and the sort of the immersion means that, you know, what you're able to do actually, you know, becomes, you know, a lot more. You know, it's really quite impressive what you can see and you know, the level of anatomical detail that you can look at. And I think ultimately that does really make a massive difference to the quality of the surgery that we can do.
Correct. I think the advances in instrumentation and imaging has improved surgical outcome and performance. And, you know, 3D laparoscopy, robotic surgery, these are all sort of forms of laparoscopic surgery which will help improve your performance. Okay, so yeah, so the next topic that I wanted to discuss was just a bit more about minimally invasive surgery and understand how minimally invasive surgery is different from open surgery, and what are the sort of we've discussed a bit about the advantages and limitations, but we'll focus now on the technical side and instrumentation and the whole sort of operating theater and environment around a surgery, the differences between open and minimally invasive surgery. The surgery by definition is invasive, and as you know, Mark pointed out, bigger the incision, bigger the sort of surgeon you are with a big ego. So when you cut open an anatomic site with an incision of whatever size, that's termed as open surgery. And you do leave behind a large wound, which is often painful and can take time to heal. Whereas minimally invasive procedure has been enabled by the advances of various medical technologies that we were discussing. And what it means that it allows surgeon or clinician to use techniques that limit the size and number of cuts or the incisions that are made. The minimally invasive procedure typically involves the use of a scanner or an endoscope or a laparoscope and manipulation of instruments with indirect observation of the field through a scanner or an endoscope on a monitor on or a display panel. So that is what we mean by minimally invasive surgery, where you don't have a direct vision of the organ that you're dealing with, but it's sort of an indirect on a TV monitor. So the word laparoscopy comes from a Greek word lapara, means this is the soft part of the body between ribs and basically abdomen. And scoping meanings to see or to view or examine. So that's what laparoscopy. It's also called cilioscopy. So some of the words which are used are keyhole surgery, minimal access surgery, or minimal invasive surgery. So how is it carried out? We said it can be through the skin, which is percutaneous, and it could be endovascular interventional radiology, example, or through the abdomen, it's be laparoscopy, through a body cavity in the chest, thoracoscopy or abdomen, and through natural orifice, even sort of mouth and anus, simple endoscopy, or now we have what's called NOTES, which is natural orifice surgery. So going into the abdomen through the mouth with an endoscope, you cut open the stomach, and then you enter the abdominal cavity to carry out cholecystectomy and appendicectomy. You remove the appendix or gallbladder through the mouth and then suture the stomach up. So everything is done through the mouth. In theory, you can do that with just sort of under sedation, and patient has no general anesthesia and no pain because it's all endoscopic. So this is what an operating theater or an image-guided surgical theater or an interventional endoscopy suite looks like in cardiology and radiology. You can even carry out minimally access surgery, simple procedures, surgical procedures, such as even taking a biopsy under CT scan or an ultrasound guidance. So let's try and understand how is open surgery and minimal access surgery different. So this is obvious, and you can imagine the trauma this would cause to the patient and the time it would take for the patient to recover from this compared to a minimal access surgical procedure. The laparoscopic surgery, as you know, is done by making tiny cuts on the abdominal wall, and depending on which organ you're accessing, you will place your instruments or the ports in the abdomen using a laparoscope, which is connected to a fiber optic cable and a light. So you would illuminate the abdominal cavity, and the image will be transmitted back onto a TV monitor, such as this, where you would look at the monitor and operate. So I want you to sort of imagine this scenario, okay, and sort of this scenario. I want you to start thinking about when I ask you how is open and laparoscopic surgical skills are different. So remember, we are not talking about patient, we're just talking about acquiring skills and how surgically things can be different, not only for the patient, but even for the surgeon for that matter. There's another example of minimal invasive surgery, the single incision surgery, where instead of making multiple ports, you just sort of use a single port, which has 3 ports inside. So you have to make a slightly bigger cut in the abdomen, but you can have a single port, single incision, with 3 instruments going through that to do the operation. You will see over here, all the instruments going through the port. The disadvantage of this is all your instruments are going to be clashing with each other, and they're going parallel or even crossing each other. Whereas one of the key thing that you need in laparoscopy is triangulation of instruments to perform a procedure safely. Robotic surgery, where you have multiple robotic arms which are connected to a console which is controlled by the surgeons. So the surgeon is actually not standing next to the patient, and in theory you could be on another place or even another continent where your console is connected to the robotic arms via internet, and the movement of the arms are controlled by the surgeon on the console. and you could perform operation using the surgical robot. There are some various obvious advantages to robotic surgery because you get 3D imaging with robotic surgery. The surgical instruments are not just sort of like pencil stick straight instruments that you use in open and laparoscopic surgery. The surgical instrument that we use in robotic surgery are like human wrist. They are sort of endo-wrist technology of robotic instruments. So the instrument that move inside the patient move almost like a human wrist, and they claim to have more range of motion than a human wrist. So surgeons enjoy the more dexterity and flexibility and control with better vision that you get of the operating area. And it's ergonomically better for the surgeon because you're standing in a nice comfortable position and operating, whereas if you're standing and leaning over a patient and you're turning and twisting, trying to look at the monitor, that does cause a lot of strain, backache, muscle ache for the operating surgeon. So ergonomically it's better, but as far as the operation is concerned, you still need the same number of ports, and it's very hard to show the difference in outcome between robotic and laparoscopic surgery, even though there are sort of number of papers claiming that.
There's also no handshake, isn't there?
No.
If you're a surgeon who has handshake, which of course doesn't exist,
Not anymore.
but the instruments don't shake.
There's lots of tremor, yeah. So we're just coming to that. There are some obvious disadvantages as well with robotic surgery. It's very expensive. You don't get feedback. The robotic instruments don't have tactile or haptics. And that requires a completely different learning curve to operate without feedback using robotic instruments. There is movement latency, the time it takes for the robot to carry out surgeon's command. It takes a few milliseconds perhaps for the computer to communicate, for the two devices to communicate with each other. And in theory, you could say that there could be risk as a result of that, or as a human error or a mechanical failure between the console and the robotic arms. And if you're a laparoscopic surgeon, it does not mean that you're automatically also a robotic surgeon. You require slightly different sets of skill to perform robotic surgery. As I said, mainly because even though you have 3D vision and endo-wrist instrument, but you don't have haptics. And in the early part of your learning curve in robotic surgery, people have found that they have higher complication rate as a result of not able to feel how tight or how loose your laparoscopic suture is, for example, if you're tying something. If you want to classify minimal invasive surgery based on a different specialty, you could even divide them into radiologists doing interventional radiology, embolization, stenting, biopsies, etc. Gastroenterologists doing number of procedures through the gastroscope and colonoscope, such as removing polyps and stenting and laser, etc. of the tumor. As surgeons, you have sort of thoracic surgeons doing thoracoscopy, or upper GI surgeons doing laparoscopy and thoracoscopy, endovascular surgery, and cardiologists doing similar to radiologists, interventional radiology. Again, just reminding you briefly about laparoscopic operation, you have all these advantages when the operation is performed competently. So let us talk briefly about open and minimal access surgery. I'm going to pause over here, and before taking you through the slide, we'll have a bit of a debate. Let me share my screen. So I'll just quickly summarize what we were discussing. The main differences, and I've just sort of classified them into operating room, anesthesia, surgeon, patient, and hospital. So the different factors under which we can discuss this topic. So as far as operating room setup is concerned, both require different setup. And when you're doing a laparoscopic procedure, pay attention to how you're going to lay out your screen, where you want to position your screen. The patient requires a thought, organizing and putting your hardware that you use in a certain orientation, depending on which part of the body you are accessing. We mentioned about anesthesia. You require GA. The second thing is for the anesthetist, it's important to know whether they need to paralyze the patient or not. Open surgery can be done without muscle paralysis, whereas for laparoscopy, you need muscles to be always paralyzed because you're creating pneumoperitoneum and you want your abdomen to be soft and not contracting or straining. You will realize if the patient is straining under general anesthesia, it means the effect of the muscle relaxant is wearing off, and the space and the cavity and the abdominal space that you have will shrink. So the access will be difficult. So, you know, these are very important points that you have to bear in mind, and it often sort of makes your life easy or difficult doing a simple procedure. If your monitor is not in the right position, you'll be straining your neck and the back. If the patient is not well relaxed, you won't have enough space in the abdomen, and you will have to instruct the anesthetist, if the anesthetist is not competent or qualified or a junior, to say that you need more muscle relaxant because the abdomen will just shrink in size. So here are a list of differences for the surgeon. As we said, open surgery, it's direct vision, whereas for laparoscopic surgery, it's remote on a monitor. Open surgery is 3D. Laparoscopic surgery is predominantly 2D, even though you can have 3D monitors nowadays. The visual field with open surgery is only, it's open and restricted by the size of the incision, whereas visual field depends on your camera operator that we mentioned and may require correction by the surgeon. The exposure itself, you know, if it's abdomen, it's wide open. You can access all the quadrants of the abdomen very easily if there is any complication or bleeding. Whereas in minimal access surgery with limited access, and the access is subject to the number of ports that you insert for your instruments and subject to the camera angle and position, whether you're using a 0-degree camera or a 30-degree camera or a flexible tip camera. You have to create pneumoperitoneum for minimal access surgery. We don't need to create pneumoperitoneum. We'll discuss in a different lecture what are the complications of creating pneumoperitoneum. And we briefly mentioned about complications from even accessing the patient for the surgery. Surgical instruments, they come in different sizes. Your standard open surgical instruments are about 15-20 centimeter in length, whereas laparoscopic instruments are 36 centimeter long, and bariatric instruments are even longer. So the difference I can give you is it's a bit like eating with either knife and fork or with chopsticks. So if you're used to one or the other, you'll find it difficult to use the other. Surgical instruments, open instruments usually don't have rotating tip. They are sort of straight linear instruments, whereas laparoscopic instruments have an additional motion that you can use, and robotic instruments, as we said, have wrist-like motions. Yeah. So even further degree of freedom and movement with the tip of the instruments. So when you practice in your box trainer, remind yourself that you've got a long instrument, you need fulcrum effect, and your tips of the instruments are rotating, which you can use, especially for laparoscopic suturing, to position and balance your needle and enhance your performance here. The learning curve for a surgeon is, you know, compared to Laparoscopic surgery, open surgery, you can say it's easier and shorter, whereas the learning curve is steeper and longer with laparoscopic surgery. For the patient, we've already discussed a number of things, but let's just summarize. You need CO2 insufflation creating pneumoperitoneum. There is no, not necessary for open surgery. Physiological changes as a result of CO2 insufflation is not generated in open surgery, whereas open surgery, the physiological response is because of the surgical trauma, whereas in laparoscopic surgery, the physiological response is generated as a result of increasing the intra-abdominal pressure. When you increase intra-abdominal pressure, you reduce the venous return, and if you reduce the venous return, you reduce the cardiac output. And by increasing the intra-abdominal pressure, the second effect you have is the mechanical effect on the ventilation of the lungs. You make it difficult for the lungs to sort of ventilate and oxygenate, but you won't get these effects with open surgery. Patients are usually kept supine or with legs up for most open operation, whereas laparoscopic minimal access surgery often requires steep head up and steep head down position. And with the pneumoperitoneum, this would compound the effect of either difficult ventilation or venous return. We spoke about pain, mobilization, cosmesis, which is better with laparoscopic surgery, return to work, wound complications, etc. Surgical complications, again, we said if done competently, laparoscopic surgery should have less complication. But in terms of trauma, physical trauma to the patient with laparoscopic surgery, it's less. You have a unique problem with laparoscopic surgery is that compared to open surgery, you are likely to have a higher incidence of iatrogenic injury, which may not be recognized because of restricted visual field. Whereas even if you get iatrogenic injury in open surgery, it's usually easy to recognize and you could rectify at the same time. Delay in recognition of iatrogenic injury would result in higher morbidity and mortality from the same iatrogenic injury. So that is one of the big difference with laparoscopic surgery. When you look at the hospital, how does it differ for the hospital? Open surgery is perceived to be usually cheaper, not necessarily. If you do open cholecystectomy, it is going to be more expensive compared to laparoscopic cholecystectomy. But depending on some operation, it could be more expensive to do laparoscopic surgery than open surgery. The length of stay is shorter with laparoscopic surgery, so you can balance out the cost by reducing the cost of patients staying in the hospital versus higher cost of laparoscopic surgical instruments. Yeah. So overall, a lot of cost analysis has been done for various laparoscopic procedures and different specialty. And you will find in the literature that the laparoscopic surgery often proves to be cheaper than open surgery, but it all depends on how you look, how many cases you are doing, how competent you are, and what are your surgical results. So in terms of complication of laparoscopic surgery, 1 in 1,000 cases in general, this is just what I'm talking about in general, will have serious complication. Things that you get which are unique to laparoscopic surgery is organ injury, which bladder or bowel, that could be as a result of access technique or your instruments, or diathermy injury, which may or may not be recognized. Iatrogenic bleeding from damage to major artery, CO2 embolization, and deep vein thrombosis, again, because of venous pooling. With increased intra-abdominal pressure, two things happen. One is you reduce the venous cardiac output, and you increase the venous pooling because of high venous pressure in the abdomen. And once again, a reminder, we keep talking about advantages of laparoscopic surgery, provided we do it competently. So that concludes my presentation on minimally invasive surgery. Malik, we are recording the session. You can share the screen. You have control.
Can you all see my screen, sir?
Not your screen yet.
Can you all see my screen?
Yes.
Okay. Hello, everyone. One second, sir. I just wanted to minimize this. Okay, all of them are there. Okay. So please, if you have any doubts, please stop me if you have any issues. I am Dr. Malik, one of the surgical registrar. I'm going to be teaching the research methods, starting from basics of literature search and then possibly referencing next week. Today, I'm going to introduce how to do a literature search. So has anyone in the group have done any systematic reviews in the past?
I've done
Please.
one.
You've done one, okay. So those who have not done, I suppose most of them are freshers here. I suppose a lot of them have not done the any systematic reviews, I suppose. So for them, this is a beginning of what I'm teaching today. So I suppose if one person has answered that he has done literature search. So what is meant by literature search? Can you please say?
Yeah. It was, for me, it was sort of an extensive and systematic review of all the literature relevant to the topic that I was looking at. So I created a set of search terms and put these into a range of different bibliographical databases, such as sort of Ovid Medline, to then get all the relevant literature specific to your topic, and then I sort of screen them for the appropriate texts.
Okay, so you've done the literature search, and so the reason why I'm started off with this is, for anything we need to understand what is existing literature, and if you want to write a paper, we need to know what are there already, and has anyone already done any publication on the subject of interest which you're looking at. So all those things are important, isn't it? So if you duplicate anyone's work, it's going to be plagiarism. So you'll be sued or you'll be having problems as well. So this is why the aim of this presentation today, first presentation, was to make you to understand the importance of literature search. And obviously, I'll also teach you what is meant by search engines and how to develop the search strategy and how to export citations. And finally, possibly next week, I'll also show some referencing the manuscripts. So are you all able to see my slides as we speak? Hello? Can anyone say, is there any problem?
Yeah, I can see the slides.
Yeah.
Yes, so is there any?
Yes.
Yes, all of you can see my slides, perfect. And today's topic, the learning outcomes it's mainly about search engines and exporting citations and maintaining database and referencing. So does anyone in the group, apart from the gentleman who has done systematic review, do you know what this search engine means? Do I need to pick anyone in the group, or just can you guys answer straight away?
Is it like Scopus?
Sorry?
Scopus or Medline?
Yes. So
Yeah.
Medline, is it a database or search engine?
It's a database.
It's a database. Okay, so what is the difference between a search engine and a database? Somebody's answering nicely.
I think database is one that contain all medical publications, but the search engine contain the research only, something like this.
So we have search engines like Google Chrome, isn't it? Google Chrome, Explorer. These are search engines, isn't it, on the internet? If you want to search some content, you want to go and type on the Google, it'll give you. instantaneous. So why are we not using the same search engines to search for the medical literature? Why do we need separate search engines?
Can I answer?
Can
It's more about the relevancy of the kind of things you search up. So when you're using something like Google, the actual kind of links and the websites which come up won't be quite as relevant to what you necessarily want to find when compared to using like these medical search engines, which will come up with very relevant kind of articles and papers and such to what the terms you searched in using.
Okay, so to answer that question, Google Chrome, Google Scholar is a search engine as well, but unfortunately, Google Scholar has not got access for every medical paper because there's restriction on the Google Scholar or even Internet Explorer. So that is the reason why we can't get all the papers if you don't use appropriate search engines. So do you guys know, anyone in the group, what are the best search engines for searching the medical literature? Anyone, please?
Would it be something like PubMed or something like that?
Yes, good. Somebody has opened. PubMed, is it search engine or is it a database? Or is it both?
Good question.
PubMed, so lots of them is like lots of queries about whether PubMed is a database or search engine or is it both. PubMed is initially it's a search engine, right? So it's designed to retrieve the articles from Medline database, but now it is used as both database as well as search engine. So it's got two functions now. So still it is search engine by definition. It's because it's designed as a search engine. What does the search engine means is like it has got access for all the databases in literature, medical literature. It can actually get the citation, and the more the number of citations it can retrieve in a search, the better the search engine. So for a search engine to be effective, what are the expectations of a search engine, like function wise? Is it like if we get like 100,000 citations, would you like the search engine? Anyone in the group? Like, for example, when you do a Google Chrome, Google search, you get like millions of citations for any subject, any topic you choose. But do you like that kind of search engine, or do you want some search engine which is very specific what you want to search?
Yes, I want the more specific.
More specific search. So,
yeah.
So that's why the search engines which are for the medical literature, they're designed to go and retrieve exactly what are the citations which are tagged papers to that word. So I'm using now word. So then comes, what is this word? So every paper, if you look at every manuscript, there are something called keywords. What is meant by keyword? So mostly you guys have to participate, otherwise it won't be interesting.
Okay, keyword is basically a word used when using the search engine that will basically always be brought up in the like articles that come up in the results section.
Mm-hmm. So the keyword is the subject of interest. Like, for example, if your title is like emergency laparotomy and risk prediction models, so what are the keywords if you expect in whole of the manuscript? Obviously laparotomy, emergency surgery, risk prediction models, or it could be anything like, ranging from PPOSM or something else, like whatever the models, names of the models. So whatever the contains. So keywords, how many keywords can you put like in a manuscript? How many keywords do you see on the title page normally?
Maybe 2.
3 to 4. 3.
3 to 4, yeah.
sometimes two also. You're right. So somebody is very lazy, they will just submit 2 keywords and they still get published, you see. So what is the function of keyword? Because the reason I'm started, I wanted to push from scratch, you see. I don't want to go jump into show you how to use the Cochrane search engines on PubMed or OVID straight away. But I wanted you guys to understand the concept of search engine first. And so that there is a lot you can demonstrate in terms of retrieving citations. That's why I want you guys to understand search engine is in the medical, especially medical literature, search engine is designed and is mainly focused around the keywords and subject of interest. So the reason why the keywords have put in place was initially before internet, all the papers which were published, they used to tag with keywords like this is Mirizi syndrome paper, and then put the library in a shelf so that they can go and identify with M and then Mirizi syndrome, and they can retrieve the article. But now we got the e-library. So they started tagging the papers with keywords. So obviously the more number of keywords, better tagging, isn't it? Anybody in the group, please?
I think the fewer better than the more.
Is it better for, if you submit more keyword, if you tag to more number of shelves, is it better or is it better to tag to one shelf?
In theory,
not one. Yeah.
If you have more keywords, so you can like easily locate it, like the specific document or publication.
Yeah. Speak out loud, please, a little bit more.
In theory, would it be more specific to include more keywords?
In theory, yes. In reality, you need more keywords. But if you ask someone to, like myself, to ask to put lots of keywords, I'll put 15, 20 keywords. Then there won't be any space for the database person to maintain your paper in so many databases. Do you understand? Like, for example, I can write colorectal, any paper like colorectal cancer paper, I can put like, I can tag with colon, rectum, colorectal, like so many keywords, like cancer, or maybe polyp. Plenty of keywords I can give, but the person who maintains the databases gets upset, which one do you need to put this paper in? He doesn't know. They're like,
so I guess the takeaway message is to have more specific and concise keywords for technicality and also searching issues, I guess.
That's right. So your subject of interest, for example, I'm saying, let's say for argument's sake, I give the example, emergency laparotomy and prediction models. Yeah. So let's say I'm doing a project on looking at the predictive models of the emergency laparotomy. For example, PPOSM is a model, ASA is a model, and something else like that. So what are the keywords I would like to put it in this, like if you give a chance, like if the publisher has said that only 4 keywords are allowed in my publication in our journal. So what can I choose, like for emergency laparotomy and prediction models? So what type of keywords can I choose? Please, somebody shoot the answer, please.
Prediction model.
Otherwise, we'll be here all day. Yeah.
Prediction laboratory.
Sorry, go ahead.
Say prediction and laboratory.
Yeah, prediction models you can do. Anything else? Like emergency surgery, laparotomy. So for example, if I show you a paper, so like I haven't actually put it any keywords, but I just wanted to show you guys the paper just so that you guys understand what I mean. Like just a minute. So I'm just going to go into my emails for a second. So I haven't, I've just written a paper. I'm just going to publish this in a couple of weeks. So this is my paper. I haven't put any keywords for this. So I've written like a meta-regression analysis showing that can the ASA grades predict postoperative mortality prior to emergency laparotomy? This is it. And I've written background, I've written methods, I've written results, but I haven't written any keywords. So can you guys think of any keywords for this title? It's an exercise as we go along.
Postoperative mortality.
Postoperative mortality keyword, yeah.
Emergency laparotomy. Emergency laparotomy.
Yeah, perfect.
You say ASA grades.
ASA grades, it could be keywords, yeah.
Meta-analysis, emergency laparotomy.
Meta-analysis, I don't think so.
I mean the 4 words.
I've actually written in the methods, you see that. I've written emergency laparotomy, surgical outcomes, mortality, morbidity. But it's not reflecting title fully, is it? So I haven't written anywhere morbidity. I haven't written anywhere surgical outcomes in the title. So sometimes the title, I've only picked 4 keywords, you see that. Emergency laparotomy, surgical outcomes, mortality, and morbidity. The reason why I picked those 4 keywords was I used those words even in searching to retrieve the literature. Do you guys understand? When I write a systematic review or when I review the literature, when I pick the keywords for my paper, I pick the keywords not just by the title, but also how I included the content into this paper. Like if somebody wants to go ahead and search for this on this topic, they can use surgical outcomes, emergency laparotomy, mortality, and morbidity. They can combine and get all these articles back. So that's why keywords are not just represents title. Sometimes it represents the body of the text, what you've written inside as well. Do you all understand what I'm saying? For example, morbidity and surgical outcomes, they are present in the body of the text of this paper. So that is why, you know, this paper can be tagged for emergency laparotomy, surgical outcomes, mortality, and morbidity. So if I give 4 keywords to the publisher, he will be more than happy to take this and then he will publish it. So that's why keywords are essential. It'll tell, it's like you're shelving something which you can go back and look inside. So once it's shelved inside, the only way to retrieve their paper from eLibrary is using a search engine. So can you guys know which is the best search engine available in the so far in our literature? Best in medical literature.
Cochrane collaboration.
What is that?
Cochrane.
Cochrane is good, but you know it's limited, isn't it? Cochrane is good, very good. Cochrane is very good. I'm going to teach Cochrane methods at some next week in a couple of weeks. But
what about?
Sorry, somebody is saying. Please go ahead.
UpToDate, is that a search engine?
Best search engine apart from Google Scholar. Apart from Google Scholar and Cochrane. Cochrane is not search engine, guys. I'm sorry. Cochrane is the database.
Database, yes, database.
Cochrane is the database. The difference between a database and a search engine is just a software designed to retrieve the data from the databases. Like, for example, a guy with Cochrane is a database maintaining, right? Somebody is in New York is maintaining all systematic reviews database. Okay, so if you want to connect to that database, we use search engine to connect it, like Google Scholar connect to the various databases. Do you understand? So the difference between search engine and database is database has got a lot of servers and it's got storage space and storage capacity, and the search engine doesn't need to be. It's just a limited software. Basically, you can even on the phone, you can get it like 10 kilobyte software, possibly less than that. So, but a database is a big, you know, it needs a lot of space and storage space. So when somebody is maintaining database, they expect it to protect the database, isn't it? So they protect the database for any corruptions, any unwanted downloads, and also they maintain for generating funds, isn't it? So that's the reason why Google Scholar is not able to get the papers from the medical databases so easily, because they're all paid articles most of the time. Google Scholar only can get the possibly maybe headings, maybe just title page, not more than that. So, but the search engines have got a capacity to go and even purchase the articles through that search engine, you see. So the best search engine, does anyone wants to answer this question again one more time?
Is it PubMed?
PubMed, do you think PubMed? I'm going to demonstrate today which is the best search engine, or live show actually.
I was thinking UpToDate.
Yeah. Go ahead.
That was an UpToDate. Is that not one?
UpToDate. I thought you guys are actually Google things. You can Google and tell me. I'll give it 10 seconds, because it's like exercise, isn't it? If I say, like, if I give the answer, you don't do anything, you know. We need to give some power to your brain to.
Yeah, I think Firefox.
Firefox is, yeah. Firefox and Explorers, they're competing. It's perfect. That's a search engine, but it's for medical literature.
For medical literature.
For medical literature, we got beautiful search engines, you know, designed for us, like eat cake and walk, like kind of search engines. Does anyone in the group knows, please?
Heard of PubMed, Ovid.
Oh, there you go. So PubMed and Ovid. So Ovid. So Ovid is a very good search engine. So what's the difference between Ovid and PubMed is, in terms of when you select a subject of interest, the PubMed and Ovid generates two different results. PubMed is more specific for current literature and actually more towards the Medline database. But the Ovid search engine has got connections with all the databases, from anatomy to surgery to psychiatry to everything. So that's the difference, because Ovid search engine has got a lot of network compared to PubMed. It can retrieve more citations. But unfortunately, the specificity and sensitivity. Do you guys know what is meant by specificity and sensitivity? When you do a search engine, Google Scholar gets like 1 million citations. Are they specific or sensitive?
Sensitive?
It's sensitive. Google Scholar is a sensitive tool, but not specific. Whereas PubMed is a specific tool, but not sensitive. Ovid is in between, you see. So it's both, it's got optimal sensitivity and optimal specificity. Do you all understand why we need a search engine which needs optimal sensitivity and optimal specificity? Can anyone answer in the group? Why do we need, like, maybe if it's sensitive, I can get more citations and I can do my literature search quite easily, isn't it? If I get 1 million citations, how much time does it take for me to read 1 million citations?
Well, it's going to take a lot of time to read all of them, and the results may not exactly be entirely relevant to what you want to know.
Okay, so that means that, you know, we need something which is like, but if you search on PubMed, it will give only 10 citations. Is it good for us to do a literature search or a systematic review?
I mean, then you also won't have enough data, so you kind of, that's why you need both sensitivity and specificity. Yeah.
Okay, so that's why we need to something in between, so that a search engine which is optimal sensitivity and optimal specificity. Is that correct, guys? So where, like, for example, if there are 300 citations, when you do a search, you get 300 citations related to subject of interest. What is meant by, I'm just introducing concept now, subject of interest. What is this subject of interest, guys? I'm sure you'll all, you know, shoot the answer.
That you are looking for.
subject of interest. Like for example, I go back and show you here in my paper. What is the subject of interest here? Can you all see? Is it very small screen, or is it okay to actually view the whole article as it is?
Yeah, the resolution is okay.
So in this article, I'm just showing my paper. This is not published. I'm sending it in a couple of weeks to publication. I haven't even put the author's name on that. So can you guys look at the title page, and can you guys look at the abstract itself, and can you guys make it up if it's, is there any subject, can you make it out subject of interest?
Is it the ASA grades?
Maybe. Who else? All of you can give a go, please. One by
one. Outcome of emergency surgery.
Okay. Okay. And who else? Anyone else want to give a go?
Would it be the post-operative mortality?
Yeah.
Maybe, you're right. So what else?
I get the impression that it seems quite synonymous with the actual title.
Yeah. So I'm very specific in the title, isn't it? So somebody is, can the ASA grades predict post-operative mortality? So it's a prediction, isn't it?
Yeah.
Whether the ASA grades can predict, that is what it's all about, isn't it? That's a subject of interest. So like, for example, ASA 1, ASA 2, ASA 3, ASA 4, ASA 5, can they predict mortality? And is there any difference in the surgical outcomes? Is there any difference in mortality and morbidity? So the subject of interest is ASA grades predicting mortality, post-operative mortality. So that's the subject of interest. So when you want to do, with that subject of interest, if you want to do a literature search, what are the keywords? For any literature search, you need to identify the keywords. So I identified the surgical outcomes. Like for example, if you operate on a patient, whether the patient dies or not is the first surgical outcome, isn't it? Do you all accept that? Hello? Can you all, can anyone answer? Shall I pick some one by one by names, or are you guys?
Yeah, we.
So is it Usman? Is it talking Usman?
Yeah, that's me.
Okay, Usman, I wanted to ask you straightforward. What are the keywords for this subject of interest? What are the keywords? I've written already in that paper, but what do you think the keywords are the best keywords for that? Sorry, I just have to.
Yes, you said 3 to 4 words roughly, so you could say post-operative, mortality, emergency laparotomy. Maybe.
So I picked the keywords emergency laparotomy, surgical outcomes, mortality, and morbidity. Are they right appropriate words for the ASA grades? So I haven't put anywhere ASA grades at all, to be honest. So sometimes you may not get that many papers when you specifically for title, if you select the keywords for the title, you may not get enough papers. That's why I went in a generic keywords like emergency laparotomy, generic keywords like surgical outcomes, mortality is generic, morbidity is generic. So if I ask like anastomotic leak, I may not get that many papers if I go for a specific keyword. So rather I pick morbidity. So it may be wound dehiscence, it could be anastomotic leak, it could be anything. So that I want more number of articles. You see?
Yeah.
So that is what it's all about. So when you select keywords, for your literature, you need to have something which can encompass vast number of articles for your subject of interest. Do you guys understand the concept, like how to pick the keywords? So you need to the keywords should encompass all the possible literature, including all the possible citations it should be able to retrieve it. I played several ways, like I tried anastomotic leak, I tried intensive care admissions, or I tried the foundations, all types of things, but the number of citations are very less. When I use these 4 keywords, I got like 3,900 citations. So is that good enough to write a meta-analysis or systematic review or any paper, for argument's sake? So I'm going to pick one from the group to answer my question. Please, somebody answer. So is 3,900 citations, is it a big number to do a literature search, or is it a small number to do a literature search? I've written here 3,989 articles.
I think it's a big number.
That's a big number, isn't it? So how much time do you think it takes to read 3,989 articles?
1 year.
1 year? Oh, perfect. You guessed correctly. We took 1 year, to be honest with you, to write this paper. So we only included 16 studies at the end for meta-regression. So there are some steps how to cut down from 3,989 to 16 studies. So these are the steps I've written in this slide. So what I did was, first I took a generic keywords to encompass all types of predict models, including PPOs and other models like NELA also, all the papers. And I developed a search strategy. I'm going to show you, today's demo is, because we don't have much time, I'm going to only do one demo of search strategy today. So with the same keywords, which I used in this paper. So I developed a search strategy. And then I got some citations. I'm calling results. They're not actually statistical results. They are the search results, like number of citations. And then I excluded unwanted. So when you do a search, even in the OVID, when you get 3,989 citations, there will be 80 to 90% are rubbish. They're not of your interest, like whatever you are choosing is still not. But we need something optimal sensitivity and optimal specificity. That's why we're adapting for OVID for bigger systematic review and meta-analysis. I also use something called filters. Can anyone in the group say me what is meant by filter? Before I do a demo, I want you guys to understand the concept of filter. What is this filter means like? I'm not using filter coffee or something like that, right? So something, I'm filtering the papers. So how do I do filtering? Like mechanically, how do I filter the papers?
Yes, when you go to specific website, you'll find a filter icon, the upper part of the page.
Okay.
And you go to this filter icon, it gives you many options. So you choose what you want in your topic, then you submit it, then it comes back with fewer.
What type of filters you can use? Like?
Can you have the English language filter?
Oh, perfect. Somebody come up with language filter. What else you can use? Anyone in the group?
Date
public.
Oh, sorry. Go ahead.
Dates, yeah.
Authors, yeah.
Dates, yeah.
Size.
Yeah. Countries.
Size.
Yeah.
Institute.
Okay, you can use all those filters, but is it hard to use that many filters? So common filters, what are the common filters we use usually to reduce the number of articles?
The date.
The date is a common filter. Why is it date is a common filter? All of you has to understand this concept. Date is a common filter. Why is it so?
Because people think outdated.
Outdated, yes. So what is meant by outdated when you say systematic reviews? What is the outdated systematic review?
Old one.
Old one. How old is it? Like 1940s or 1970s? Or more than 5 years or more than 10 years? Which?
According 10 years?
Yeah, please go ahead. All of you answer. Any number you can pick from 1 to 40, 1 to 50. Yeah.
According to what I want. Sometimes I need even the old.
Even the old. How far? Like for example, if I go back to my subject of interest again, I've given you the example. My subject of interest is this bit. What is this bit? Is I'm looking at the ASA grades. is my subject of in predicting power of post-operative mortality and other surgical outcomes. So how far I can stretch myself to
Don't
get
want more than 10 years.
more than 10 years?
I don't want more than 10 years.
You don't
That
want
means-
more than 10 years. So
Yeah.
can you justify why you don't want more than 10 years?
Because I want the new approaches in these 10 years.
Yes. So what we want is, number one, why is it so important last 5 to 10 years is there are some advancement in surgical field, right, in the last 5 to 10 years. So the postoperative care is better nowadays, and we are admitting into a high dependency unit, intensive care units. So all those concepts were not there if you go back more than 10 years ago. And the type of ventilators we are using, type of monitors we are using, technology we are using is advanced last 10 years. So if you want to compare the surgical outcomes, you want something similar, isn't it? You can't compare a lemon with a big, orange or something like, or something bigger fruit, you see. You have to have same kind of fruits. So you have to have same kind of papers, like same kind of standard. That's why last 10 years, yes. And why is it, I said something more also, usually how often you can do a systematic review on the same subject of interest. That's the next thing. Or a literature search. For example, if somebody has written on the same subject like 3 years ago, am I allowed to do literature search and write a paper again on the same subject? Can anyone in the group, please?
I think because it is meta-analysis, I can include it, no problem.
Okay, so if somebody like, let's say for argument's sake, last year, the same guy has published meta-regression on the ASA grades predicting power of mortality. Now I'm sending this for publication. Will it get accepted or will it get rejected? I'm including the same, let's say for argument's sake, last year, guys, 16 papers, he published 16 papers he included for qualitative and data synthesis. And now I'm including same 16 papers for qualitative and data synthesis. Is publisher is going to accept the paper, my paper, new paper?
No, it'll be most likely be rejected, and I think it's like 5 years. I think it's either 5 or 10. You have to wait like until it's accepted again.
Yes, it's good that you wait for 5 years, but sometimes yes, it's best you wait for 5 years on the same subject of interest if you want to do another literature search, because you can get more original studies added into the literature, isn't it? A literature search is nothing but you're just looking at other people's publications and summarizing the concepts, isn't it? So you want more original studies added as we go along, isn't it? That's why the longer you wait, the more original studies will be added to the list so that you can have more number of original articles for your meta-analysis or systematic review, whatever you want to do. So you need to give sufficient time so that new articles will come through the door. Do you guys understand the concept? So applying filters, the date and time is so important. If you pick like 20, 30 years, you'll be doing it, your MSc or PhD for rest of your life. So if you pick like 5 to 10 years and your subject of interest, if it's simple and easy topic, you'll be finishing systematic review or literature search or meta-analysis quite quickly. You're not expected to do meta-analysis for your MSc, but you're expected to do the systematic reviews. So that's why applying filters last 10 years is a good idea. I would go with 5 years. And if there are less number of citations, then I will extend to 10 years. So then comes what is meant by limitation. What is this? Filter and limitation. What is the difference between limit and filter? Guys?
Yes.
Anyone in the group, please?
The limitation is the thing that you don't want, I think.
Limitations, like for example, we are human beings. So I'm giving you a clue. So how can we limit articles? Quite a lot of.
So you could filter for like clinical studies or laboratory studies or animal studies and limit to only having some of those.
Yes. So limitations, you can limit for original studies on human beings and exclude animal studies, exclude laboratory studies, and exclude like phase 1 trials, phase 2 trials, phase 3 trials, only include phase 4 trials on human beings. Something like that. So limitation is like exclude animal studies and things like that. So then what you do is when you do a search, you get some citations. In the Google Scholar, if you do any subject of interest, it will get like million citations. Can you export all those million citations onto your Word document? You can, right? Technically. Hello? No one is answering the question.
It's difficult to make citation for this number.
So it's difficult if you have more number of citations. It's difficult to export because you need a lot of storage space in your computer. So if the million citations which retrieved by Google cannot be exported, but the citations, if you use appropriate search engine, you can limit the number of citations you can export and then download it as a Word file so that you can go through. So then comes shortlisting. Like for example, if 10 candidates apply for one job, so 9, maybe 6 gets shortlisted out of 10 applications. Like that, among all the abstracts which you get it, when you export it, you shortlist relevant abstracts and get rid of the abstract level itself. Why is it so? Before I go to next slide, I want to give this. It's very important that you exclude at the abstract level itself the non-relevant articles for your subject of interest. Why is it so important? Because it becomes very expensive for your librarian as well as for your institute to buy all the articles, right?
Yeah.
So each one costs £30 or $30. If you submit like I need 1,000 articles in a Word file to librarian, they will throw you out, go and join another university, they will say. Is that correct? So we need to get like maybe 30, 40 citations, maybe 100 citations you can ask the librarian to buy it if they don't have on the database. So that's why you need to include those abstracts which is relevant for your subject of interest. So I'm saying again, subject of interest. Subject of interest is not a single keyword. It's a mixture of keywords. Do you all get this concept? Like I'm going to run this show, run the demo at the end. What is meant for the same paper which we have written. So going to the next slide. Once you got beautiful subject of interest for all your thesis, you need subject of interest. So once you got a subject of interest, like let's say COVID-19 is the subject of interest. It's a burning topic, isn't it? Do you all agree that COVID-19 is a good subject of interest? And you can see how many papers, rubbish papers are getting published every day. So there you go. So you need to be subject of interest. Currently burning topic is you need to pick some subject of interest so that you can progress. At the moment, anything you write on COVID-19 gets published in one journal or the other because people are eager to read. So when you choose subject of interest, you need to target the audience. This is more important. What is meant by targeting audience?
You want your audience to read your paper?
Yeah, so you want your audience to read the paper, yes. So I say like, for example, this paper which I've written here is the emergency predictor, right? So ASA grades as M. So which kind of journals I can target? Can I send it for newspapers? This no. Can I send it?
It wouldn't be for doctors only.
Can I send it for somebody like maybe Law Institute or something like that? I can't, right?
Yeah.
So you need to target. So which kind of targeting journals can I submit this to?
Surgeons.
So can you name one journal of surgery which is famous in the UK?
Surgery.
Surgery, okay.
And that of the Royal College of Edinburgh.
Yeah, British Journal of Surgery, yes. And what else? BJS, yeah, British Journal of Surgery. What else? Lancet. Can I send it to Lancet?
Yeah, I think that yes.
Can I send it to Nature?
No.
No. So Nature actually goes to the general public.
Yeah, yeah.
So you can't target this kind of articles to Nature, do we? So this is targeted approach. That's why when you choose subject of interest, you need to write. You need to choose the subject of interest, which audience you're going to target to. Okay. So some people may have their intentions behind why they choose. Like I have my own intentions why I choose target audience as a surgeon, only surgeons, because I'm a surgeon, as simple as that. Okay. So next one is, now I'm going to go to the real practical life of how the search engines and what are the search engines, and we can play a little bit with search engines once I do this. So to clarify, these are all the search engines which are commonly used by us. So I've written Cochrane Library as also a search engine, because here there is a debate, because when you ask for Cochrane Cochrane database maintenance people, they have their own software within in their computers. They can search and give you citations separately, but we can't access their library. We don't have access for their library by ourselves unless you got a paid membership or something like that. But whereas Ovid, PubMed, Google Scholar, Web of Science, and ScienceDive, these are all like free ones. Like you can do a search any number of times. And if you want to buy some articles, there's a pay-per-view on the Ovid. You can go and do that. So common things I use for my systematic reviews is Ovid and PubMed. And I'm just exemplifying what is meant by keywords. I've given you my own example, and I'm going to exemplify. I'm going to give another example. Like, for example, a keyword can be pronounced in different ways and can be actually expanded and can be abbreviated in different ways. Let's say, for argument's sake, if you want to do anything on the CT virtual colonoscopy, I've written here so many keywords because the people started using, if you go to St. Mark's, they will say CT virtual colonoscopy. If you go to some other hospital, they will say CT colonogram. If you go to any other hospital in outside London, possibly they use CT virtual colonoscopy as the word. But CT colonogram is used in some parts of the London. CTC as in some parts of the London, but CTVC and CT virtual colonoscopy are commonly used. So that's why when they publish papers, they can include all the keywords. They can put these keywords as CTC or CTVC or CT colonogram. And when you use only one keyword, like CTVC, you may not be able to retrieve all the citations. That's why if you got multiple keywords for a subject of interest, when you do search, you have to include all the possible keywords. Do you guys understand what I'm saying? Okay. Limitations. I've even limited for last 15 years also when I don't have a subject. Like, for example, when I did a Mirizi syndrome systematic review, I didn't have much of subject of interest of number of papers published. So I even went for last 15 years and mainly included English articles because I don't know the German language. You see, most of the Germans are always competing with us. So they will publish a lot of literature, but I didn't have that skills to read their papers. So I only limited most of the time to English literature and mainly human beings. And if you want to do a meta-analysis, it's best to get the good level of evidence. We'll talk about level of evidence at some time later, but you can, if there are so many articles published on a subject of interest, if you want to limit, another limitation you can apply is randomized controlled trials. That's the best papers you can get it. But most of the time you don't find much of randomized clinical trials. The main reason is most of them, they won't get approval for human studies, especially randomized controlled trials. So there are not much randomized controlled trials. If you go on the COVID-19, hardly there are 1 or 2 studies in the last 6 months. So there are some search methods, common search methods. PICO was original search method. What is search method? Anyone in the group, please? We got another 10 minutes to finish the presentation. Anyone in the group, please? What is meant by search method? No one is answering.
Is it just to make it easier for the audience to find what the paper, really?
So I said like there can be multiple keywords possible, right? For a subject of interest, there can be multiple types of keywords possible. Like for example, let's go back to our example. I've written here 4 keywords: emergency laparotomy, surgical outcomes, mortality, and morbidity. So when I want to use, how do I combine, how do I, let's say, for example, if I use emergency laparotomy, there will be plenty of papers, right? Let's do that. Let's do a bit of Google work. So I'll put it here, emergency laparotomy. Because I want to take you slowly rather than in a rush, you know, so that the concepts gets stronger and stronger. So how many citations? 221, is it 22? 2,200,000, you know, it's like, how many? Quite a lot, like 1 million citations, 2 million citations, possibly, on the emergency laparotomy. And if I do the, let's say, I'll do the, let's go to PubMed now. Let's do PubMed. So one at a time. In the PubMed, let's put emergency laparotomy. How many came through? 7,469. So there's a 2 million there in Google, and there's a 7,000 in PubMed. Let's go for another one. Are you all able to see me, what I'm doing?
Yeah. Yes, we can see you.
Yeah, okay. Ovid search engine. Let's go to Ovid. It's a free software. We can play with this. Oh. Ovid. So I go for browse articles like pay-per-view, basically. So and then I don't have login. You see, I'm not a student, so that's why I'm using the browse per view. So you get the window like this on the Ovid, and I'll put the emergency laparotomy. Let's do how much it comes. Let's see. Emergency laparotomy. Let's enter it. How many have come through? 1,308. Not many, isn't it? Are you all able to see my screen?
Yeah.
Yeah.
Okay. I'm going to display the results and let's see. So there's a lot of papers, like 1,300 came through. So emergency laparotomy. So for one keyword, you got like 1,300, right? So you can go through, it takes maybe 2-3 days to go through, or maybe to go through all things. But let's go back and let's go back. You guys, can you see these citations like abstracts here? All has got emergency laparotomy in that. Can you all see? Emergency laparotomy, evaluating improving current risk prediction tools in emergency laparotomy, oh, quite a lot. So every title has got emergency laparotomy. Perfect. So let's go to the Ovid box. PubMed box. So how many has got emergency laparotomy, rural emergency, elderly emergency laparotomy? Everything is emergency. Okay. So perfect. So there is a difference between both. This has retrieved about 7,000, that has retrieved about 1,300. Right, so next thing I'm going to go is, why is it so important that we need to have a methodology, why to do is, I'm going to get a little bit of exercise to the mind before I introduce concept of PICOs and spider. There's nothing major there. So I'll write like maybe on surgical outcomes. Surgical outcomes, let's see what happens. I'm using and. I'll tell you what is meant by and, what is meant by or, and things like. How many we got? When I use emergency laparoscopy and surgical outcomes, it limited to 1,895. So let's go back to the Ovid. Let's go back to Ovid and then see what will happen. So let's type surgical outcomes. So if I say surgical outcomes, there's 50,478 articles. How much time is it going to take to read the 50,478? Anyone?
Quite like multiple years.
Maybe 5 years, something like that, isn't it? So if I say 1 and 2, what will happen? We'll see. 1 and 2, like writing, like creating a method, like writing a search strategy, writing a strategy. Then when I apply, when I say emergency laparotomy and surgical outcomes, the Ovid engine has limited to 103. Let's see if they're okay. Yes, laparoscopic colorectal emergency. There's the word emergency, that's why it brought it. So emergency laparotomy, second one is relevant. Granulomatous, it's not relevant. Third one is not relevant, you see. Epidural anesthesia and emergency abdominal surgery, fourth is relevant. So there is some sense, there is some lack of specificity, but it's able to get some decent number to go through, isn't it? So, and also it's reproducible. So for any search engine, if you do it again and again, it should be reproducible, isn't it? So if you say that to the publisher, when I sent this article for publisher, I said that a total of 3,989 articles were retrieved through 2 different searches, both in PubMed and Ovid. Then when he does the search, he will get like 50,000. Then he will think that Malik is a he's bluffing me, he's a liar. And then he will throw it in the bin. So any search engine should be reproducible, like results should be reproducible. So, and if the search engine only works if you develop a search strategy properly. That's why we need some methodology. So people come up with solution like, okay, so when you're doing a systematic review, you need to give a like population. Here is emergency laparotomy. Those who are going for emergency laparotomy are called population. The intervention is, the patients who are having surgical issues is a population. The intervention is laparotomy here. And the comparison is ASA grades here. The outcome is mortality and morbidity. So that's how the technique they used, PICO, like population is those patients who are going for surgery. And second thing is intervention is laparotomy. Comparison is ASA grades is a comparison I did in the paper. And the outcome I'm looking is mortality and morbidity. So then comes the York University came around and said that I'm going to add S to that, like PICOs. So population remains same, intervention remains same, comparison remains same, outcome remains same, but they introduce study type. For example, there are randomized controlled trials, prospective studies, retrospective studies. Does it matter? Anyone in the group, by using PICOs, is it more specific or is it more sensitive compared to PICO?
More specific.
More specific. So what happens when a search strategy, when you build it, if it's more specific, what happens to the number of citations you retrieve?
It's going to go down.
It's going to go down. Okay. So eventually people started hating PICOs because it is more specific but less sensitive. PICO is original a tool which is developed by someone else. I forgot the name of the person, but the PICOs is been like highlighted quite a lot in UK. That's why I'm picking on PICOs. So it's specific but not sensitive. But some other guy came and said that I'm going to invent another search methodology called SPIDER. So where sample here is those patients who are going for laparotomy. Phenomena of the interest is outcome, basically. What type of, is it patient dying or patients having any complication, anastomotic leak or something like that. And then design, is it a prospective design, retrospective design? Then evaluation, like what are the differences between mortality, morbidity and things like that. And research type, whether it's a lab-based study, human-based study and things like that. But what happened with the SPIDER technique was, can you guys think of what happens if you use that many number of, like I want Malik to be wearing glasses, wearing mustache, wearing a suit, or wearing this. So what happens, like every time I come to your class, I should be wearing all these things. What happens to a person? Like how much time does it take for a person to get ready to that level of expertise?
More sensitive and more specific.
More specific. So you're going more and more specific, right? Rather than more sensitive. So you are defining like, okay, my number of papers should be like this, like that, like this, like that. And at the end, you don't have any papers when you do a search with that. The SPIDER has complete utter failure, basically, because the number of citations have decreased. So PICOs, the problem is it's a specific, optimal sensitivity. The SPIDER, other way around, is less specific, more specific, less sensitive. And the PICO is more sensitive and less specific. So which one do you want for any search strategy? If you want to build a search strategy, which one do you prefer in this PICO, PICOs and SPIDER? I'm the beginner and you are all the beginners. So what would you like to have?
Have the more specific.
You want more specific. Okay, which one do you want to choose then?
SPIDER.
SPIDER, perfect.
Yeah.
Okay. So people have tried SPIDER. Yes, there are some publications on with SPIDER search strategy. So what will happen with if you use a broad search strategy, you get lots of citations and you can filter among them. If you use a narrow search strategy, you'll get only less citations. There is a likely chance that you will miss some papers. That's why we need something which has got optimal sensitivity and optimal specificity. We can stick with PICOs, to be honest with you, but the only problem I'm facing with PICOs is the study types. You won't get that many RCTs, you won't get that many prospective studies, that many retrospective studies. So at the end, I'm still going back to old school and going back to PICO, because I wanted my articles to be published with inclusion of all the published literature for the last 5 to 10 years. So I spend extra time in going through the literature, you see. So yes, if there are lots of papers on a subject of interest for COVID-19, possibly I can use PICOs because there are maybe already 1,000 citations there. So I can use PICOs. For a subject of interest, like for example, let's say plasma therapy for COVID-19, hardly there will be like maybe 10 papers, 15 papers. So if I use SPIDER or PICOs, I may not get all those 10, 15 papers. Rather, I use PICO. So it depends what is the subject of interest, which one model, which method you're going to choose. If your subject of interest has got lots of publication, go for something specific. You can use SPIDER. And if your subject of interest is neither broad nor narrow, then you go for PICOs. If your subject of interest doesn't have any publications at all, go for a wide search, of the literature, which is a PICO. Do you all understand how I'm framing your search strategies? Okay. Anyone in the group, does anyone have any doubts about it?
Is it possible for you know how you went through SPIDER and you said, for example, the sample would be the patients that have laparotomy and the interest is the outcome. Is it possible to go through that with PCOS?
You can do that, PCOS, yes.
Would you be able to take a sample?
I did publish a paper on PCOS methodology, systematic review on pancreatic lesion, cystic lesion of pancreas. You can do that, PCOS, yeah. So population, which is the population is emergency laparotomy group, those who are going for emergency surgery. Intervention is surgery, laparotomy. Comparison is morbidity and mortality, like anastomotic leaks and things like that. Comparison, sorry, my apologies. Comparison here is the ASA grades and all the tools. Like for example, the subject of interest is predicting power of ASA grades. So comparison here is between ASA grades like ASA1, ASA2, ASA3, ASA4, ASA5, PPOSM, NELA, and things like that. The outcome is mortality, anastomotic leak, and all other complications like morbidity, like wound adhesions and other things. Study type. Possibly, if I have a chance to use, I'll use RCTs, but you may not get RCTs that many. So you go for prospective or retrospective studies or cohort studies sometimes.
Thank
You
you.
understand what is meant? So do you all understand the concepts? The concept here is, depending on your subject of interest, you need to pick which methodology here, which suits for you. If someone asked me to do a systematic review on plasma therapy for COVID-19, which one do I pick in these three?
You SPIDER because you said that there's lots of
PICOS,
right?
There are not many. Plasma
there's not many, then PICO then.
Then PICO, yes, there you go. Perfect.
So that means I should be resilient.
Yes, you need to
yes,
be
if I want this more, I want this more. Yeah.
I did with PICOs, one paper, and this paper is with PICO. The one which I'm published now is PICO. This one is published this PICO method I used.
Yeah.
Okay. So I'll go back to the presentation because I'm doing a demo same time. But I'm going to tell you, when you do this PICO or PICOS or SPIDER, whatever methodology, you can, well, you're all bright chaps. There are 15 students there. You can come up with SPIDER Web or something like that in the future, and we will encourage to publish in papers, you see. So what I'm saying is, like, there is a way to mix P, I, and C, and O. So that is what is all it does, and or limit not filters. These are the terms, these are Boolean terms, which can, you link P and I and C and O. Which one to link, which one to filter, which one to get rid of it. So what and does is, can you all see my screen here behind me? Can you all see my screen?
Yeah.
Right. So if you, like, let's say, for example, let's say this circle is, let me do this. So let's say this is, can you all see my screen? Big circle I'm drawing.
Yes.
So let's say this is P. Yeah. This is I, which is intervention. So what does and do? What does R do?
I don't think you can see the writing.
Oh, sorry. So let's say circle on the right side. Okay. Shall I move the? Yeah, I'll move the camera closer. Perfect. Can you see?
It's still kind of faint.
Faint. Okay. Can you see? P.
Okay. Yeah.
I. I'll use a better screen next time. Sorry, today I'm not prepared very well. So P is the population, I is I. So if we use and, what does and do?
It will combine them like a Venn diagram.
So if I use and term, let's say and I'm using, what and does is P circle, I circle. This is P circle and I circle. This is what is and. Can you all see the one which I marked here in the center? When I overlap two circles, the overlapping is called
overlapping. Yeah. Also Venn diagram. Yeah.
Is it less compared to P and I together, or is it more?
Small.
Small, isn't it? So the AND function reduces the number of articles. So what does mean is the AND function should have both P and I together in the articles. Population is those who are going for emergency surgery, and the intervention is laparotomy. So if the papers, if you use AND function, it will only get those papers which has got emergency surgery and laparotomy. So that means the number of citations are only limited to this part of the circle, where the both circles overlap. Do you guys understand? So I'm going to say now, what does R do?
I'll get both of them.
Both of them, like make a big circle.
Big circle.
Do you understand now? R will increase, so it add both, like both apples and oranges, it will add together, P and I. So PI. So what does not do then? Let's say I hate York University people and I don't want S to be included. I will say
it'll exclude one of them and narrow your search.
Yes.
Yeah, narrow the research. Yeah.
Not S. Okay. Not animals, not human beings, or not study type. So I use not. That means I want to get rid of that. You understand? Yeah.
Not.
So not excludes the stuff. So if you guys understand the concept which I'm building here, so P, if you use AND function, you'll only get that many citations, which there's overlap between two circles. If you use R function, it will combine both. Okay. So I hope that's what I needed that chart for. I hope all of you understood what I've done. Okay.
I just want to understand, what do you mean by AC? AC, you said AC1, AC2, AC.
What is that? Say again.
You said AC, I think, before you do this. AC1 and AC2 and AC3. AC3.
AC1, AC. What is AC?
Yeah.
So AC is the grading for the patients, you see. Americans have designed, the anesthesiologists have designed the grading. For example, a fit and healthy gentleman is ASA1. And those who has got like maybe mild disease, like let's say diabetes, so ASA2. An old gentleman with diabetes, maybe ASA3. And old gentleman with diabetes, heart failure, or something else, ASA4. So as the number of diseases increases, there will be more. So the higher the grade, the more chances of having more complications, you see.
So
I'll introduce the whole thing when we go along. I'll show you the whole systematic review on how we do it and things like that. But I just want to give you the concept because it's a beginning. This week is a beginning, and we don't have much time to demos. So next week I'm going to go take a bit more into depth of search strategy. I just want you guys to play with these functions like OVID and PubMed and R and see what will happen. Okay. So I used here 1 and 2. You get 1 or 3. If I say 1 or 2, what will happen? You see, I use 1 or 2. Can you see how much number it came? So it added number 1 and number 2 together and has given 51,6083. Why is it exactly same? Like, for example, if you add numbers from 50,478 plus 1308, it should be 6 at the end, right? 8 plus 8 is 6, but it's only 3.
It's because some of them are included in both searches.
What is the word called? If some of them are included in both.
I think the 1 and 2 are included, so you won't have the exact.
It's called duplicate.
It won't duplicate, yeah.
You got duplicates, so it'll remove the duplicates. Okay. Perfect. So I showed you how to use UND function. I showed you how to use OR function. So how to use NOT function. Let's use, like, for example, what are the search terms we used here? Surgical outcomes, emergency laparotomy, mortality and morbidity. Let's go back to that. Mortality. So mortality has got how many? 20,000 citations. Morbidity, let's type morbidity. How many citations we have? Morbidity. 12,000. Let's add all together, like mixture, like 4 or 5 or 6.
3,000 something, 4,000.
So I'm just teaching you simple things, but as we go along, search strategies will become more complex, yeah? But at the moment, I'm just showing you how to use this and or not. That's all today. So we got how many total? 4 or 5 or 6, how many? 10,000. 4, 5, 6. Is that it? Is that it? So what it did was, like, it pulled 4, 5, 6 together, and it only gave us 10,271. Do you all agree with that?
Yeah.
Okay. And now I wanted to see animal studies. Animals. So how many studies are there with animal studies? 16,000. So now I'm going to use 7, not 8. 8 contains animal studies, right? I'm using function not now. Can you see this now? Yeah. So in the step 7, you got 10,271. When you exclude animal studies, when I say use not, obviously it reduced to 239, 10,239. Do you all understand how to use not function? Yeah? Does anyone have any questions about this before I go a little bit more? Before I go to next slide. Okay. So that is the basic things I wanted to teach all of you. Does anyone in the group has got any doubts about how to do such strategy? Can you apply same in the PubMed? I haven't shown you in the PubMed, right? I've shown you only in the OVID. If I use all the things, let's say emergency laparotomy or surgical outcomes, $8 million, sorry, 875,967. Do you now all see what's the difference between OVID and PubMed? Anyone in the group, do you appreciate that the number of citations the PubMed is giving is vast compared to that of OVID? Does anyone in the group disagree with my statement? So that's why PubMed is not a great search engine, you see. It may be a basic search engine, but it's not a great search engine. That's why we need something comprehensive. That's why I always prefer to use OVID search engine, because you can do again and again and again and again, and you can show to the publisher or editor or other people that, okay, this many number of citations are possible and this many number can be retrieved any number of times. And so in the demo, I would like to show limitation to the number of years. You see that? So here, you can limit to original articles. I'll select that. Do you all see that? I selected original articles, and also I can select the publication year. So I can select from maybe 2000, maybe last 5 years, let's say for argument's sake, from 2015 to 2020. So, and then that's it. You press enter, it'll go automatically, search. So it'll apply the filter. So can you see that? It applied limitations. So limit to last 5 years. So it became 1853. So the UND is a filter. OR will combine UND is going to filter the articles. That's what I want to tell you. Next thing I wanted to show is if you wanted to choose review articles, you can choose review articles only. It will give you review articles separately. And there are no review articles on this, to be honest, because we already selected original articles, you see. And let's say I'll delete this step 10 and step 11, remove it, and then I will select again review articles. Let's see how many review articles are there in this. So we don't want review articles. Do we need review articles for any literature review again? There are 105 review articles. No one is answering my questions. If you're doing other literature search, you can quote them as a reference, but you can't use them because it becomes plagiarism, right? Yeah. So for a literature search, you can quote them as references that so-and-so guy has published and so-and-so guy has missed something. That's why I'm doing another paper, blah, 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 like that. But you can't actually reproduce these things. So I can use I can limit again to original articles. So when you do a limitation, you first, if you want to get rid of review articles, first you do a step for review articles, and then you say that 9, not 10, or something like that, so that it'll get rid of altogether all the articles, rather than pressing original articles. So this is another way you can do it. Okay. So this is second way I'm showing you. And there is another thing. So now we got, let's say for argument's sake, we got 10,134 citations. How do we export on this? There's a function here. Can you all see print email export?
That's it.
So can you all see in my screen? Print,
yeah, we can see.
Print email export. Yeah. So if you use the function export, if I type that, it'll ask me how many citations, maybe first 10 citations I'm exporting. Let's say I want search history as well, and you format, we need a Microsoft Word or maybe PDF, yeah. And then whole citation, style, and I want search history as well. And then it'll ask export, then it'll ask you email actually. So it's straightforward, download complete actually. I'll show you first 10 citations, how they exclude. And the search strategy will also be exported as it is. Can you see, guys? Like step from 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. This is called search strategy. All the steps which we developed as we go along is called search strategy. And these are the citations. When you export it, it'll give you beautifully like what is the title, author, a year of publication, and there's a link for full text as well. Can you see this? That's why I like Ovid. You can export and save it, and the whole search strategy will come as it is, you see. And you can reproduce this again and again. I hope all of you have enjoyed this. Does anyone have any questions about this?
I just had one question. You know, when you press review articles, number 10, does that include just review articles of the emergency laparotomy surgical outcomes, all of the previous things that you've written?
Yeah, that's right. So when you limit it, that means it's only limiting to that above step, the step before. Like when you limit using limit 9, that means whatever there is in that step 9, it is limiting. It only takes that citations out of 10. I'm written here, limit 9 to review articles. That means that in the 9th step, we got 10,239 citations, right? It's limiting to review articles is 105. So only 105 are there review articles. Now I'm writing again to see, I don't want review articles, get rid of them. So 9, not 10. You can do that way, or just simply type original articles. I'll go back there and type original articles. It's the 10,134, you remember. I'll go back here, 10,134. Let's remove that steps here. Instead of this step, I'm going to show you that. So just remove it here. You can remove that steps. And then what I'm going to do is limit, you just select original articles and then search. So how much it came? 9,180. Can you see the difference between what I did and what it showed? So there is a difference between number of citations there, number of citations here. Which is better? So when I said original articles, it's cut down like a knife with a big knife and say 9,180 are the original articles. When I was saying review articles, it's only took 105 away out of 10,239. That means there is a discrepancy. That's why I wanted you guys to understand that not the same, the search strategy which I'm writing in both two ways, it yields different citations. So ideally you should go through both if you're doing a proper systematic review or a literature search. Do you understand?
Yeah, that makes sense. So it's all like all the steps just add on to each other to narrow your search.
Yes. So even 9,180 is big number, but I would now reduce it to something less. Let's say, for argument's sake, ASA. $8,000. So 10 and 11. Let's say how many it comes. Maybe 1,000. 11. Can you see that? Literally 11 papers, 10 and 11. It's no, first one is not related at all. Second one is not related at all. Third one is not related. Fourth one not related. Fifth one, maybe fourth one related. But ASA means you need to define ASA grades rather than ASA because ASA can be drug as well, right? That's why, you see. Remove. Let's go back. ASA grades. ASA grades. So 10,000. Can you see the difference? I used small letters ASA and it gave me different number. Now ASA grades, it has yielded me 10,150. Now let me do 10 and 11, see what happens. There's lots of ways you can do such strategy. Now it yielded 14 and previously it yielded 11. So let's see what is the not relevant, not relevant, not relevant, not relevant. So my search strategy is failing. So what is the reason why when you use randomly like this, it fails? And we need to have a proper search strategy. That's what I'm going to teach you next stages. So when I'm using ASA grade straight away, applying filter with that of emergency laparotomy surgical outcomes, it's utter failure. All the 14 citations which we got it is completely not related, irrelevant. Because there is a problem with search engines itself. That's why I'm going to guys teach next week how to write the search strategy, the steps of writing search strategy. So there are some steps for writing search strategy. But before that, I want you guys to understand that there is a basic steps like and, or, not, and limitations, filters. And if you guys are familiar with this, I can take you to next level, how to get the relevant articles related to ASA grades, rather than just showing you simple search. There is a way we need to write it. That's what is the next stage. But before that, that's advanced search I'm going to show you in the next sessions. But before that, I also wanted to introduce the concept for referencing. Do you guys all use referencing software? Anybody in the group here, please? If anyone is using any reference software, can you please open up?
Yeah, I've used EndNote.
You use EndNote, and anyone can think of any other reference softwares?
CiteThisForMe.com.
Okay. Who else? Anybody think of anything else?
I think Microsoft Word does have its own citation program thingy.
Any word has got citations, but it's limited, isn't it? You can't change it, isn't it? So why is it so important? Any reference? Why do you need referencing software to write a paper or to write an essay or to write a blog or anything like that? Why is it so? Anyone in the group, please? We're running short of time. We only got 15 minutes. You need to speak up, please.
Or not to fall on plagiarism.
See, people like their quoting their work, isn't it? If, for example, if I say that, okay, I've done a breath test on a colon cancer patients, and I got all the molecules which I borrowed it from a different person, and then I say that, oh, I found it in my colon cancer patients, but the other guy has published on upper GI cancer, and so that is his previous work. If I'm copying someone else's, if I don't reference, will it be an abuse for the previous author, or is it a lawsuit?
Yeah, could be.
It could be both, isn't it?
Both of them, yes.
It
It's
could be
a crime,
both.
yes.
So
It's a crime,
it is a
crime.
crime to copy someone's work
Yeah.
and then publish as if it is your own work. So you need to
Yeah.
reference it. So the why you need a referencing software is because it's a methodology. You know, you need to have proper referencing. Like, for example, if I go back to my paper, my students have done beautifully referencing here. Can you see it? Bibliography. So author's name and then title page. Beautifully they referenced it. Can you see this all? So, and if you don't use a proper software, you cannot export these citations and you can't change the style of citations. For example, here, this is one style, which is a constant Vancouver style we used here. There are other styles like they just start with the first author name rather than number 1, number 2, number 3, number 4. If you look at the text, when we are quoting like for example, wherever we are quoting in the introduction, let's show the citations in the introduction. Let's so here, if you look at it, I've written here 9, 10, 11, in brackets. These are like numbered citations. So you can even write author's citations, Mr. Uppara et al., Professor Patel et al. You can write like that. So different ways of citing it. So here I'm writing number 9, number 10, number 11, and I'm going to show them like number 9, number 10, number 11 here. What is this? Number 9, number 10, number 11 is, these are authors like number 10, 9, 10, 11. That is one way of showing it. Other way of showing is like author's name itself. So there are 100 ways of showing the references. That's why we need a proper software, isn't it? Do you all agree with that? Does anyone disagree with my statement that we don't need any proper software? We just can use the word and then get away. Can we?
It's better to find a proper software.
We need to have
easy.
software. So
become more easy.
Yeah, so we need a software that is easy for it to access. We need a software that is easy to purchase. So I would all recommend all of you to use Mendeley. So it's a free software. It's a free software. You can create a database like this. I created my own database. It's a free software. You can register and you can download all citations so easily. Like, you know, here you can see the Mendeley desktop, Mendeley online Mendeley reference software. I'm using it. You can see here in the left-hand corner, add new citations, add entry manually, and it'll give you DOI number and PubMed, or sometimes even gives you PubMed number, PMID number. So I'll take you through those, how to add references into your local database, into your computer, and also how to add it online into your Mendeley next week when I do that. But before I go too far, I want you guys to have one kind of software installed on your computer so that we can play next week when it comes to demo. Is that okay, all of you? So I would prefer, Mendeley is a free software. You just go on the Google and type Mendeley software, any software, Mendeley. Just Google search Mendeley. You get Mendeley referencing management software. You just download and it'll ask you email and register. It'll send a password. You register it and you plug into Microsoft Word and you start using Play with that. So that this is your homework, so that I don't need to teach every little bit of it. Do you all understand? So I prefer Mendeley because it's got various styles you can choose, multiple styles, like hundreds of styles you can choose, referencing styles. That's why I prefer it. And also you can maintain your own database online as well as on your desktop, and you can even manually add it. For example, some studies may not be published, so you can even add manually, like add entry manually. So this is what important, like, and you can even import from library. You can import from other computer as well, from USB stick as well. So that's why I like this Mendeley. So I'll all recommend Mendeley to use it because it's a free software, and you can use any number of desktops with the same username and password. Okay, but I don't know how much protection it offers with your computer, but my computer not got corrupted with Mendeley software so far, to be honest. I'm going to do a proper demo how to reference with the Mendeley software next week because we are running short of time. It's only 10-15 minutes left. So I would like to conclude this literature search today. So what I would suggest is you guys all have to play with this search strategy terms, and all of you has to do some homework. Choose a subject of interest, any subject of interest. Let's say on COVID-19, maybe do you guys wanted to break down yourself into 3 or 4 groups? Shall I give an exercise for you guys for the next week to show your screen to see what search strategy, like this, you guys have to give me like, so search strategy is this bit is a search strategy called, the steps here from 1 to 11 is called search strategy. You can see on the top, it's written like database, PPV, general, so with search strategy. I want you guys to start developing search strategy for COVID-19 treatments. And I want to divide into 4 groups because there are 16 people here, isn't it, in the group? So would you all take, one of you take a lead and please start doing a different search, write search strategies using and or not, and send me an email before next class so that I will know how much you guys understood, so that when I do advanced session, I'll teach you how to do a proper search strategy. And then we'll go to referencing. First you need to know you need to get the citations first before we can start referencing any paper. Do you all understand?
Do we have your email as well?
I can share my email here. I can type here if you want all, I'm typing here. You can all drmallikarjuna@gmail.com. So some homework for all of you. So that's my email, drmallikarjuna@gmail.com. So the exercise I'm giving you for homework is COVID-19 treatments. So the word treatment could be many things like drugs, it could be plasma therapy, it could be ventilation, it could be non-invasive, it could be ECMO, it could be many things. So I want you guys to use all search terms possible towards COVID-19 treatment and give me the search strategy and develop a search strategy. And I will show my own search strategy and we'll compare. When we do a search strategy writing up, there will be difference. It should be specific, and at the same time it should be sensitive. So you can use any of these, Pico, Picos, or Spider. but I want you guys to practice how between P and I, is it R or and? Between I and C, is it under R? Between C and O, is it under R or not? Do you understand what I'm playing with? Words. Yeah. So if you guys start writing search strategy, that is your first step that you can get citations from literature. That's the basics of it. So once you get citations, I will show you how to upload your citations onto Mendeley Desktop. And then I will actually, next step, I'm going to go take you next level, how to make it a systematic approach of reviewing the literature, which is called systematic review. And then if there's a data, I will show you how to do meta-analysis as well at some point. So I hope you all enjoyed, and if anyone have any questions, please ask me now.
I don't understand the numbering in Ovid.
Sorry, say again?
6777. I don't understand the numbering in Ovid.
This numbering,
which is 6767. I don't know. You're right. 10 or 9 or 10, not 8, something like this. I don't understand what.
You don't understand? Okay.
Yeah.
Let me tell you. So I'm going to zoom here. It's very important because search strategy development. I'm zooming it. Can you all see now? Search strategy.
Yeah.
It's the simplest search strategy. I haven't done anything magic in that. I just wanted to see how many papers are there. So here, number 1 is emergency laparotomy, which is P, right? This is big here, P. And surgical outcomes. Surgical outcomes could be which one? Is it PICO? In the PICO, which is that circle?
In I think.
It's not I. Surgical outcome. O. Another circle. O. So mortality is again in the PICO. Which one is that mortality? So I said. So let's go back here.
Yeah.
So emergency laparotomy is it intervention or is it population group or is it in the PICO? Let's say PICOs. Population group could be.
It's intervention.
It's population group. It's intervention. Emergency laparotomy is intervention. I, right? I. And what is the surgical outcome? It's O, isn't it?
Yes.
So between I and O, I written like I and O.
You get all of them. You get all of them.
So I and O means only you get this much. This, let's say, this is I.
or.
So IO is where there is both things, like number will be small. If I say I or O, what will happen? Then it will all combine together.
Yeah.
Do you understand the steps?
Yeah.
Okay. So what is mortality and morbidity? Is it O or is it?
Mortality or morbidity. And that means to be all of it. The mortality and morbidity, all the 2 circles.
It's still O, isn't it? It's still O.
Yeah.
Now you're getting the point. So it's still O. So mortality and morbidity is still O.
Yeah.
What shall we do with O's? All O's, what shall we do?
We combine them together.
Perfect. So there you go. You are thinking now. So all O's we combine. All I's we combine. All P's we combine. Do you understand? That's the next step we're going to take next week.
Yeah.
All P's I combine. All I's I combine. All C's I combine.
Yeah.
Do you understand? All comparison.
Yeah.
All the A's grade is a comparison. You need to combine.
Yeah.
Develop advanced search strategy.
Yeah.
So for COVID-19, what is the P here? COVID-19 and drug therapy. What it could be P, what could be I, what could be P?
Drug therapy will be an intervention.
COVID-19 is it noun, isn't it? COVID-19 is a noun.
Noun, yeah.
So it is P, right?
Yeah, P, yeah.
COVID-19 is a P. So drug treatment, let's say plasma therapy. Is it I or is it in the PICO? Which one? Plasma therapy. Where does it stand in PICO?
I think it should be in I.
It'll be in the I. So let's say patient has died. Where does it come? Is it outcome or is it comparison?
Outcome.
Outcome. So let's say if somebody was ventilated and non-ventilation, non-invasive and invasive ventilation, where does it stand?
Intervention, something.
I'm saying if there are two groups, one is invasive ventilation, other one is non-invasive ventilation. Where does it stand in the P code?
It starts in the middle.
Comparison, right?
Yeah, comparison, yes.
Okay, so all that kind of words you club together, all comparisons you club together, all I's you club together, all P's you club together. So COVID-19 is also another P you can think of. Any other P you can think of for COVID-19? Coronavirus.
Coronavirus, yeah.
Yes, other. So just think of COVID. So think of other P's. All P's you can combine together using R and not and R. You should be able to play with that. Yeah. And start writing. I want you guys to, 4 of you club together, 4 group together. And I want you guys to send me a search strategy you guys can think of. And I'm going to show my search strategy and we'll compare and how we play. And then I'm going to take next step, next level of writing up search strategy. You all understand? And at the same time, I'll also show the referencing next, like using the software Mendeley a little bit more. Okay. And if you all got Mendeley desktop or something installed on your, and I can show you when I do, you guys, same time you do it, when I do it. Yeah. Like same time I say, add reference and quote reference. So I'm going to show you how to merge citations, all those things, like step by step. Yeah. Anyone in the group has any questions before I conclude this session? We got 5 more minutes to conclude this session.
Yeah.
Anybody, please, I can't get the names here. Let me see the names. I don't know why I'm not able to see the names. Present, okay, let's exit full screen. Oh, there you go, participants. So there's one person dropped actually. So shall we go one by one? Like Usman, do you have any questions for me?
I think I'm okay so far. If I've got anything, I'll just email you.
Okay, so you guys have to email me the search strategy, how you're going to, that's your homework, yeah? And also the Mendeley desk or any kind of reference software you need to install on your computer, free softwares. Jeremy, do you have any questions for me?
No, I'm actually, I was wondering where I could access these slides on QM+, but couldn't find where I couldn't find them.
I'm going to say, because I've sent it Prof only last week. Prof hasn't uploaded this yet, so Prof is going to upload with the video, you see.
Oh, okay, that's fine. Thank you very much.
No problem.
I think that's it for me.
Yes, and anyone, Cyrus?
Yeah, no, I've got no other questions. I think Jeremy asked the question that I was going to ask.
Okay, Matthew?
No questions from me.
No questions. Chardawa?
I don't have any questions as well. Thank you very much.
Have you understood the concept of search strategy and subject of interest, these concepts?
Yeah.
Okay. Dr. Silo?
No questions.
No questions. So you're able to develop your own search strategy for COVID-19, do you?
Yeah.
Can you? Yeah, okay, perfect. Artemis, do you have any questions for me?
Oh, no, thank you. Oh, I've been added to 2 groups, so I think we should like communicate a little bit better with the groups.
No, 4 of you form a group and, you guys discuss among yourself, which is the best strategy, how to combine P and I and C and O, which is P, which is I and C and O. You need to identify those first. And you guys have to practice a little bit. This is hard, but initially, as you go along, it becomes a child play, to be honest. Okay. You guys have to make a little bit group among yourself. Yeah. Charlie, do you have any questions for me?
My only question with this search strategy, so obviously so if we're going to identify the PICO, is it just on COVID-19, or can we go because obviously COVID-19 in of itself doesn't have like a comparator or like a setting. So do you want us to sort of make up our own one?
Oh, there is plenty. Do you want me to give the ideas? COVID-19, plasma therapy, drug therapy, and then you say phase 1 clinical trials, animal studies, laboratory studies. So what else I can think of?
So do you just want us to like you say, make it up? So pick.
Up,
yeah, sure thing. Yeah.
Make it up. Yeah. Make it up your P as much as you can.
Yeah.
The bigger the P, bigger the citations list, you see. So what else I can think of? COVID-19, coronavirus disease. So P is, you have to, there are so many ways you can use the COVID-19 word. Coronavirus disease, coronavirus, COVID-19, COVID. So all this, there is different. If you use all those combination, you'll get so many articles, you see. And what else I can think of? So the treatments like steroid usage, HCQ usage, hydroxychloroquine usage. Why is it being discontinued? So you can compare all those things. Randomized controlled trials is a word you can use. Like you can use PICOs as well to see if there are any RCTs. Yeah. You can use any prospective studies, retrospective studies. There are so many ways you can write search strategy. And we can compare to see which is the best search strategy among all the four groups. Okay. Dr. Yusuf, do you have any questions for me?
I'm not a doctor, I'm a medical student, but
okay.
No questions. I was just about the slides, but you've already mentioned that, so yeah, that's fine.
Slides will be there in your thingy.
Okay,
we'll upload. Kamal, is there any questions for me? Kamal? Dr. Kamal?
Yeah, you mean Kamal Al Mahbub?
Kamal Al Mahbub, yes.
Yes, I'm okay. I'm a bit about the numbering, but I will understand it, no problem.
Sorry, are you able to follow my lecture, or is there any?
Yes, everything is very clear, but this numbering, I couldn't catch it up very good yet.
Okay, it's only today. I haven't gone any depth. Okay, is this the numbering is just for demo purpose? To be honest, when I do proper search, I'll show you which to combine, which to not to combine, where you combine, like which steps. I'll show you next in the advanced searches. But
yeah, okay.
That's just to give an idea what is meant by and, what is meant by or, what is meant by not. That's all.
Yeah.
Today's goal was to explain what does and function do, or does, and what is meant by filter, what is meant by limitation. That's all.
Yeah.
So if you guys, and what is meant by database, what is meant by search engine. Okay. If you guys all okay with that, last assessment, I'm going to, you guys have to shoot the answers now, one by one, quick.
I just had a question.
Yes, yeah.
When would you like this completed by?
By next week, before I come back again, by Friday.
By Friday, okay, perfect.
By Friday, yeah, sorry, by Friday. COVID-19, drug treatment, steroid treatment, invasive ventilation, non-invasive ventilation, plasma therapy, all those things you can see how many papers are there. I want you to get all relevant specific articles, and the search should be sensitive also, specific as well as sensitive. Okay, and we'll pick up which is the best search strategy among all the four groups. Okay, so before I complete this session, would you be able to answer this question? Is Ovid a database or true or false, please? Please shoot questions. 2 minutes. We are already crossed 1 o'clock.
False.
So Ovid is?
It's a search engine.
Perfect. Is PubMed search engine or database?
Mainly a search engine.
Right? Search engine.
PubMed is search engine. Is PubMed a database?
Database, yes, yeah.
It's initially designed as a search engine. It's also a database. It links to Medline. So it's both, you can answer both, it's correct. So DOI and PMID numbers are used for referencing. Is it true or false?
True.
True. Und-in-search strategy will increase number of citations. Is it true or false?
False.
False. Or-in-search strategy will decrease number of citations. True or false?
False.
Okay. So full citation is not essential for referencing. True or false? I'm reading questions.
False.
Full citation is not essential for
Oh, sorry,
referencing.
true. No, wait. It's essential, right?
Is it essential? How many of you say essential? How many say non-essential?
I say not essential.
Full citation is not essential for referencing. Is it true or false? How many of them say true?
False.
So full citation is if you get full citation, that is okay. If you can't get full citation, it is not mandatory. Okay, so it is false actually. Filters can be used to limit the articles for last 5 years. Is it true or false?
True.
Yeah, true. Authors and journal permissions are required to download citation onto Mendeley desktop or any reference manager. Is it true or false?
Good the question.
Please think about it. Authors permission and general permissions are required to download citation.
False.
You don't need permission to download citation.
Yes, no,
Yeah. Okay. You don't need any permissions from anyone. Search strategy development is a basic requirement to conduct a systematic review or meta-analysis. Is it true or false? How many are saying true? How many are saying false?
Didn't catch the question.
Search strategy is required, a basic tool which is essential to do a literature search or a systematic review or meta-analysis. Is it true or false?
True.
True. So that's why you guys have to learn search strategy, how to write appropriate search strategy. That is the next step. That is what is a homework for all of you. Is that okay? And also before you come to next session, you should all have one kind of free software, referencing software, so that when I do demo, you should be able to understand, yeah? Play with the software a little bit. Okay, thank you all of you. And Prof is going to speak now. Prof, do you have anything, Prof? Any suggestions?
Hi, Malik. You want to stop sharing your screen?
Yeah, I'm going to stop sharing my screen. Just a second, sir. Stop share. Okay. Yeah.
Lovely. Thank you. I think everybody must be toxic now. We'll take a break.
You need a break, yeah.
Good.
Was it okay, Prof?
Well, I mean, yeah, good. I mean, we'll see. This was the first session, basic session, so I'm sure everybody's a little bit.
Yeah. I'm trying to encourage them to participate. They should participate.
Yeah, I think we'll the last session that you were using will quiz on Mentimeter so that they can actually vote, and you know how many people have replied.
Yeah.
So we'll do that. But anyway, let's catch up for about 1 hour after a break. So I'll see you here at 2 o'clock. Okay. And Malik, if you can wait, we'll just just a quick chat.
Yeah.
So come back at 2 o'clock. So in this session, I'll talk briefly about academic writing, and then I'll just show you a practical skills video for the lab skill module, and we'll just discuss some theory of laparoscopic skills training for those exercise in that module. Who's a fan of essay writing? Do we have any? Or not just essay writing, but who likes to write or is an author? Any of you have written stuff?
I've written
like stories or poetry, or doesn't have to be public research and publications. Just writing.
I got so bored during quarantine, I wrote a book just for fun.
Oh, wow. What did you write on?
Oh, it's just a collection of short stories because I don't think I have the patience to write entire continuous novel.
Oh, no, man. So one thing I'll suggest you all do is, just like how people have the personal diary and holiday diary, then, when you're old and retired, you can read about it. Keep a medical diary. Make a medical diary where you don't note everything every day, but when you come across a good case or a good presentation or something that you've learned in the wards or in theater, that you saw something interesting, you make a note of it just as a reflection or as a sort of a short story, and something that has a learning point, something that you have learned or you think somebody else would learn, or some examples of, you always get asked about leadership skills and teamwork and team working well. Where, give us an example of this. So you'll see it day in and day out, not during MSc, but in your clinical posting, in your future training. And you can build up a nice portfolio of interesting cases that you treat, that you've come across, interesting people you've met, or conference, and that you can, when you're 50, 60 years old, when you look at that encyclopedia you'll have, it'll be very fascinating and interesting to see as you start your journey into treating patients and providing patient care. And I regret not doing that. That's what I'm telling you, because I wish I had, because, so many interesting patients you come across, so many interesting things that you see in hospital. So this is all that you sort of get to see and get to do in hospital, which is what I'm talking about. And if you keep a short log of that as part of your clinical posting, you do 12 deliveries and you take sort of 6 or 10 history taking an examination, but that is very, very, it's a tick box exercise. But if you start writing, it'll not only help you develop your writing skill, but it'll make an interesting document to read later on in life of some good and bad things that you saw in the hospital building that nobody gets to see other than you. I mean, doctors, basically. And writing, publishing, presenting is one of the important part of this MSc. I keep repeating the two main blocks or the pillars of this MSc is developing your surgical skills and developing your research skills. So I'm not going to teach you how to write essays and make you a fantastic writer, because writing is something that you've been doing from primary school. You've done a lot of writing. And similarly, scientific writing is not something that you're unfamiliar with. You've done in your medical school submissions and essays and various things. But just to help you focus, when it comes to publishing a paper or writing up a thesis, you require a slightly different skill. So I hope from this short presentation, our aim is to help you understand specific ideas and improve your ability to explain literature or the topics that you're searching in your own words. So the key point over here, which again you learned in the literature search, is to try and focus and narrow it down. With writing, you want it to be structured and argue your points. And within the scientific framework, it is sort of evidence and not opinion. So you want to show evidence. You want to sort of give hard facts from the literature, from your research, which is what scientific writing would be. So the word essay comes from Latin verb exbre, which means examine, test, and drive out. What do we mean by that? It's a sort of purpose of discovering knowledge, making a point, sharing information, synthesizing information, analyzing a topic, document your observation, or it's basically all of the above. So writing is a process where every writing assignment is practiced for the next one. And if you go step by step in a focused manner, then it'll definitely make it easier when it comes to publishing paper. Now, essay writing used to be part of the MSc, where we had essay submission, 6 essay submission in the first semester. But I have moved away this year for the first time from essay submission to just having quiz and MCQs to test the knowledge, rather than testing your knowledge by asking you to submit an essay. We will ask you to submit a couple of essays just as a, not for assessment, but in-course assignment to develop your writing skill. And not only that, but to see your writing skill, because everybody is different, and we can give you feedback and tell you what you can do to improve your writing skill. So you always structure your essay, even if it's a short section, even the paragraph is structured in such a way that you start with always writing an essay or describing something, or even practicing for an examination or a viva. You always frame it in such a way that you start with definition, pick up the keywords in the question or the topic, introduce the argument. For research, you'll have data for analyzing, raising counter arguments, and concluding. So it's a sort of balancing both the sides. In terms of preparation, you saw everything should start with literature search, PubMed, Ovid, or whatever search engine you use, apart from a standard surgical textbook. So that way you can broaden your knowledge. The idea is not just sort of picking up one textbook and expecting to find everything in that book. So literature search is one of the key research skill. Make sure that you practice, and you'll get lots of opportunities to sort of revise and practice. And even though you may not have understood today because this is the first time, but throughout the year, you'll have plenty of opportunity to practice, rehearse, or come back and repeat in a one-to-one session if you're not sure with the tutor. Once you do good solid literature search and you're confident of doing that, you're essentially, it's like, you know, you're confident of fishing. You're fishing in the ocean where you have millions of articles and textbooks and journals and all. But once you identify a topic and focus on that, you can fish out what you want from the sort of sea of literature. Group discussion is another very important part of preparation of essay or writing a scientific thing. Discussing within the group, peer-to-peer, or with your supervisor, tutor, or even externally. It all forms part of refining and helps you consolidate your thesis or research idea if you're working on that. And using brainstorming technique. So once you've done a bit of literature search, bit of discussion around it, and once you think that you have enough knowledge or understanding of the subject, then you sit down with a pen and a paper or on the computer where you list your ideas, mind mapping and clustering, just or freehand writing. By mind mapping and clustering, what we mean is, you know, as you see in this slide, and let me just go back to the previous slide. Yeah. So let me enlarge that. So you start with your central theme or whatever topic you want to write about, and then you keep adding. That's your title. And let's say you have 4 keywords over here, as you saw in literature search. This becomes your literature search is similar to a clustering idea, where you've got your PICO principle, the PICO, and then you've got alternative words, and then you combine all that and structure that. So if you're discussing, say, management of acute abdomen, for example, if you want to write an essay on management of acute abdomen, you write down over here, management of acute abdomen. So what all things do you want to cluster around acute abdomen? You can say, you can start with definition of acute abdomen. Then management includes presentation, investigation, treatment. Treatment can be open surgery, laparoscopic surgery, conservative surgery, indication for surgery, contraindication for surgery in acute abdomen, etiology, pathology. So once you cluster things down, you can then structure in a way that you can produce a good scientific paper. Obviously, you will not start with operation and then come down to etiology. So you always follow in a chronological order. Sometimes you have to be mindful of word limits, if there are word limits, in which means on a simple topic, you can write a whole textbook, a 500 pages, 1,000 pages textbook to a 500 word abstract, something. So you should be able to sort of convey your message or summarize in 300 to 500 words, which is what is usually required, even if you do PhD, to submit an abstract for oral presentation in international seminars and conferences. Yeah. And your oral presentation is decided based on how well you convey your view and your findings in those 300, 500 words. It is sort of in a PhD, which normally takes about 3 to 5 years worth of research work and data, you have to sort of produce in a small abstract. Yeah. So everything has to be relevant, logical. You use language, charts, diagrams, things which are easy to follow and understand. And that would lead to an understandable conclusion in a logical fashion. I'm not going to go through this step-by-step process where you're reading, searching, brainstorming, then you again go back and reflect. It's a process, as I say, where there's a lot of going forward and backward till you consolidate what you want to write, how you want to write, things that would include, as I mentioned, bullet points, charts, figures, paragraphs, to cut short and restrict your word limit. For your thesis writing, you have a word limit of, I think, 11,000 words. So, depending on your topic, you may be able to write a lot more than that, but you should be able to condense it in such a way that you can convey your message in 11,000 words for your thesis. Yeah. So in introduction, when you're writing an essay or a paper, you always start with introduction, where you define the topic, explain why you're writing, which is sort of talking about controversies and the current knowledge in the literature. And you mentioned the aim and objective if it's a scientific paper. Yeah. In the main text, again, you go on to define the topic, supporting evidence and conclusion. For each aspect or each block you write within that scientific literature, you break it down so that it is a logical beginning, middle portion, and conclusion. These are some of the tips on writing style, being short and clear, logical. So very obvious things, there's nothing new that you don't know of. And for formal writing, you avoid metaphors and figures of speech and don't use lay terms. Just like your PICO for searching literature, a useful strategy for writing just a paragraph is, I call it PI, PI, sort of your main point that you want to make. So you write the text, the main point that you want to make. You illustrate using charts, tables, and figures. And then you explain about that illustration, what it means. Yeah. So that makes it readable. The same topic you can just convey in, you know, one A4 sheet paper, which is just basically alphabets and words and sentences from start to finish. Or if you want to sort of make it look presentable, easily readable and understandable, then you follow this sort of a structure where you start with introduction, make your point, show things in illustration, charts, figures with explanation about what the illustrations mean, and that way you can convey your message clearly here. In terms of data presentation within an essay, you have numeric data, descriptive data. You learn about data and statistics more in detail and how to present this data in research method section. But use diagrams, visual demonstration of data, flow charts. I'm sure you've done this in some form of presentation, bar graphs or pie charts. They all sort of make it very easy to understand and read rather than just sort of reading through sentences and sentences. Yeah. So whenever possible, you have a bit of explanation on what this graph is, then you have the actual graph and the meaning of the figures or whatever is there in the graph. So that would form your whole paragraph. Writing tips in describing a chart. So you don't just sort of throw in the chart. Well, here's an example, summarizing the information in a chart by selecting and reporting main features and make comparison very relevant. A lot of the time you see people just sort of write down or create a pie chart or a bar chart with different colors and just put down numbers. But it's unless you read the whole paper or the whole thesis, just looking at a chart, you don't get the information as a reader unless you've read everything. Whereas if you look at this chart, I use my mobile phone or tablet, 27% people have done that. So there's a brief explanation, there's a percentage, there's a number to show what each sector represent, and that makes it easily readable. So make sure when you describe a chart, every time you're describing something, it should be a standalone entity and easy to understand on its own without having to go through. Obviously, you won't understand everything just by looking at a chart only. You have to read the text. I'm not saying you don't have to read, but make it as user-friendly and reader-friendly as possible. You will have a talk on plagiarism and referencing, so I'm not going to cover on that. Editing the essay, a lot of it is now just done on the Microsoft word processing, especially grammar, language, spell check, etc., etc. Once you've written your essay, finishing, one of the things that you should do is read it a few times or give it to somebody else to read and comment on the contents, not necessarily just sort of on grammar. Which again, the best thing is to work in groups when you're writing something. And hence, when you look at the papers that are published, you have number of co-authors in a paper or within a research project where everybody has a different role that you take it up in doing the research as well as writing up the research. So don't think that you can just simply add your friend's name on a paper that you have done research and published. There has to be a legitimate contribution. Conclusion should always include a short summary talking about the limitation of your work or the data that or the research that you've done, and some key messages and questions for future research and understanding. So I think with that, I'll stop talking about academic writing and writing skill. There's not a lot to discuss, but if there are any questions or anything that you know you want to raise or not sure about writing, anyone? Good. No question. So for the first module, which is lab skill, the practical exercise that you're going to be doing, there are three main tasks: peg transfer, pattern cutting, and needle loading, which is handling a laparoscopic needle, so that once you are able to load the needle in the correct position, then you can move on to the next module, which is laparoscopic suturing. So is everybody familiar with LabPass? You heard of it? Yes, no?
LabPass.
Yes.
Yes. Let me show you. So if you just suture, Google LabPass, it'll bring you to this ALS GBR LabPass. Now all this information and instruction is there on QM Plus, but since you don't have access to QM Plus, you can even read it over here about LabPass, and the demo videos are also available over here. So you have these sort of different tasks. Task number 1, which is what your LabPass first module is. You can play the video over here. You can see.
This is task 1 of LabPass, grasping and manipulation.
So we have these videos on our QM Plus as well. So the first is task number 1 and task number 3 that you're doing for the first module, and the information is all over here. Once you have access to QM Plus, you'll find it over there as well. So let me take you to QM Plus and show you. So you just Google QM Plus, it takes you to our, this is the Queen Mary University online platform. Once you get your email address, Queen Mary email address, there'll be some alphabets and numbers. You can log in over here.
But still gives me a guest.
Sorry?
A guest. It is still giving me a guest count.
Yeah.
I don't know.
So you don't have full access with guest account.
So are they going to convert it to full access?
Well, they should.
Yeah. Okay.
They should. So just give me a second. So you come on to the home screen and you'll have the modules. You can, when you see this 4 square over here, that sort of takes you to your dashboard, and you can pin the modules over here. So let's go into the laparoscopy skill. So that's the one. So that's a brief description of the module, aim and objective, and then we got a list of this. These are the sort of PBL webinars or the theory topics that we are discussing, and these are the practical skill that we're going to be doing. We've included some optional tasks which you can do for developing your basic laparoscopy skills. Then you can see over here, the lecture videos are pre-recorded and will be available. So next week, we are going to be discussing let's say, role of simulation in surgical training. So I'll expect you to go through the video lecture, go through the slides, role of simulation surgical training. And if you go over there, you will find not only slides, but you'll find some journal article or a PDF or extra reading resources that you can use, so that when you come here on Tuesdays or Fridays, we have an interactive session rather than either me or somebody coming here and presenting you slides. So we can move away from that. So just bear that in mind. If you don't come prepared for the session, you will lose out. So we got the slides, you got the lecture videos, and then you got the tab for practical skill, which gives you instructions. So if you click on the task number 1, which is polo, here's the instruction on what you have to do. So the first task you have to do in 4 stages. So let us look at the first task. Let me start from the beginning. The aim is to develop your eye-hand coordination, depth perception, and 2-hand maneuvers. And this is actually, this slide shows the competency target. As I told you, there are only 2 validated curriculum available. This is the UK version, which is what we're going to focus on, LabPass. And I've kept the US version because we have some Canadian students in the, and overseas students who are interested in doing FLS. So you have to finish this exercise in 4 minutes without errors. And this one you have to finish in 300 seconds. I mean, 300, maximum time is 300 seconds, but you have to finish in 48 seconds. This is just sort of transferring 6 pegs over here. The exercise is divided into 4 steps. So I'll take you through the steps now. It starts with transferring 3 objects from base to 3 post. So you can see that a soft pad with 3 vertical poles. What you will get in your box will be a plastic pad with 3 plastic poles and plastic polo ends. Now with each exercise, I'll tell you how to make things better, and you can improvise and you can use some homemade models. Sometimes they're easy to use than plastic models. So here you can see there's just a little sponge and 3 matchsticks. You can strap it to the board so that it does not move. So you start by using your left hand, transfer the 3 objects. Over here is polo from base to the first post. So you start with your left hand. So what you have to note is how is this polo being held in this instrument. You can be holding it in line with this instrument, or you could be holding, the instrument could be going vertical like this if you hold the polo from the center. So when you're practicing, try different permutation, combination, different angles, practice instrument handling. Don't just focus on the exercise. What you're focusing on is instrument handling as well as your laparoscopy skills to see how you can speed up and do this in 4 minutes. And if you've seen the instruction on method of teaching, I've told you, you should video record your performance and play it alongside this video. I want you to watch the video on QM Plus at least twice a week and critically appraise as to how the instruments are moving, what's the angle, what's the position. Now step number 2 is you pick it up with your right hand and then you rotate the polo 180 degree and you place it onto the second post. So once again over here you have to observe the angles, the movements. You can rotate your wrist, pronation, supination, or you can rotate the instrument. Step number 3 is you remove the polo from the second post and you transfer from one hand to another mid-air without dropping it. Now, anytime you drop a polo or you don't get it on the post, you go back to square one, and that adds to your time. So you see how it's difficult to finish in 4 minutes. If you drop the polo, then that's, you go back to the first post on the floor, pick it up, put it in post 1, post 2, post 3. So if you reach step number 4 and you happen to drop it, then you go back to step number 1. So this is step number 4, where you use a 15 centimeter string and you pass it through the center of the ring. To improve your depth perception, you can come closer to the camera. If you move away from the camera, your depth perception will be difficult. If you see, look at the position of the instruments. See the right hand and the left hand. You always want the instruments to be triangulating so that you form a triangle that when the two tips of the instrument meet, and it's not an acute triangle, but it's sort of 90 degrees, coming at 90 degrees. So if you're struggling, you reassess the object or the model that you're practicing. See if it is in the right position. See if you need to move it a bit closer or a bit further away, etc. You focus on time and you focus on economy of movements. You can rotate the polo just a little bit. Bit of pronation, supination at your wrist with your right hand and the left hand can improve your vision and orientation so that you can complete this in time. The next exercise is pattern cutting, which is you've got a circular ring. So what I suggest, you'll only get a single rubber pad with your box trainer. And you can use a glove. So if you just buy a standard glove from, especially now you get the box of glove everywhere. Buy one box of glove and you cut only one surface, just pin it down to a cork board or something. So use that as a model for practicing over and over again, and your target time is 3 minutes. It's precision cutting, where you're just using the tip of your scissor for fine cutting. So over here, this is you can see a dark inner circle, which is a 5 centimeter in size. All the instructions are there on the QM Plus and on LabPass. So you just draw a 5 centimeter circle, and then with this dotted line from the center, 5 millimeter, make an outer circle and a 5 millimeter inner circle. and then you're supposed to cut just the line. You can go clockwise or you can go anti-clockwise. If you touch the inner or the outer line while cutting with your scissor, or if you cut the line, you get a penalty. So, and you only cut one layer of the glove. There are some sort of simple, cheap stuff available on Amazon and eBay. Will send you information that you can buy. Even the white gauze that we use, you get non-sterile gauze. You'll get a box of 100 for £5 or something. It's very cheap. It's probably cheaper than a box of glove. But you just pin it down or strap it to something on a book or a corkboard, and make sure that the whole model does not shake and move in your box strainer. And this is sort of focusing on your bimanual skill. And precision cutting. When you come for your assessment, we are not going to look at your time that you finished in 1 minute. So the assessment is going to be both subjective and objective. The objective assessment is obviously the time limit, but the subjective assessment would be using, there are Likert scale and checklist for assessing laparoscopy skills. Yeah. In terms of how do you handle the tissue, you will be marked from 1 to 5. How are you handling the two instruments? Handling of the tissue, all that will be taken into account when it comes to marking. But for lap pass, it is usually just the error and the time. So your MSc assessment are not just purely based on time criteria. So there is both assessment, objectively assessed and subjectively assessed. Another thing that I want to tell you is once you get your laparoscopic instruments, you don't necessarily have to straight away connect it to your laptop and practice in 2 dimension on the screen. If you've got an empty cardboard shoebox, place the model in the shoebox, and under direct vision, as you are doing open surgery, but under direct vision, using laparoscopic instruments and using the shoebox as for your fulcrum, do it under vision, which means that you're practicing in 3D as if you have a 3D laparoscope. And we've done research, and there are other papers in the literature that have shown that if you acquire skills in 3D, your performance is much better in 2D with a shorter learning curve. So there is some benefit in practicing few times under vision so that you develop the finger, brain, motor neuron connections, motor skills, and motor muscle memory with regards to instrument handling and the angles and positions and everything, orientation. So you cannot use your box as an open box training, but there's merit in doing open box training by using just a simple cardboard box, placing the model inside and doing it directly under vision. So I would encourage you to do that. I'm not going to show you task number 3, needle loading, because that'll be information overload. We'll go through that. There are some optional tasks that also I've kept over here. Here's an example of sugar cube stacking. It's interesting to just do something different because you get bored of doing the same thing. And over here, what we're doing is just sort of get some 10, 15 sugar cubes, place it in front of you, not at the back of the box, and then let's see how big a tower you can make. So this also helps you develop your tissue handling, instrument handling skills, apart from bimanual and depth perception. Okay, I won't play through this, but just to give you an example. So there are many models, a simple exercise that you can use for practicing and developing your skills. Yeah. Good. Now, what will happen is you will practice, and then when we come here online, you will play your video and we'll appraise that and give you feedback. Alex, who's going to be taking most of these sessions, will be interacting with you and doing the same thing. We can have some live sessions. One of you can connect the box and do it online. So this is how we are going to do your assessment. Let me show you. So you can see the screen?
Yeah.
Yeah. So this is one of my students. She just finished the MSc program as a distant learning student. And that's me giving instruction.
There's length.
Laparoscopic suturing, yeah, 2 interrupted suture, about 15 centimeter in length, 2 stitches.
So what I'm using as a motor is a glove, which I've.
Yeah, that doesn't matter. You can use anything you like.
Okay, I was using the pad with the towel.
Can you hear the computer audio? Everyone?
Yes.
Hello?
Yeah,
You can.
Yeah.
Yeah, I mean, you can use that whichever you want. I'm going to just mark you on the 2 interrupted sutures. So that is fine if you want to use that.
Yeah, I've just done it on that. So.
That's fine. So you can see how easy it is to actually see you practice even online. But this is time consuming. So 2 things. The first thing is you'll demonstrate how you load the needle in the correct position, and then you'll take 2 interrupted sutures.
If you guys can't see what you're seeing, if you're not seeing what, just let me know.
Now, once you go in, I'll see the.
Yeah. Right, yeah.
I mean, I can see you on the small circle. I'll be able to see it better once you're in.
Okay.
So you just bring your needle, hold it close to the camera so I get a close-up picture of that.
Yeah.
Yeah, good. So I can see your step 1, that's fine. So I hope that's clear. Initially, we'll have a bit of troubleshooting with setting up your box that you have to assemble and getting the angles right and instrument handling and all. So don't get too stressed and disappointed because it is going to happen. Okay. Setting it up and getting things going. But as I said, practice on an open box while you get familiar and comfortable with your own box. It'll take you some time to get comfortable with your own box as well, yeah? In terms of your height, your position, instruments, and everything else. Yeah.